Three, two, one. Please start, sir.
Good morning to all of you. Today again we are here on second Sunday of the month of March of 2024, and we are here for another program of FOGSI ICOG PG clinics, which is being running for more than 2.5 years. And before I start, I would like to express my sincere thanks along with my team of Dr. Ashish Mukhopadhyay and Dr. Hafizur Rahman to President FOGSI, Dr. Jaideep Tank, Dr. Parul Kodawala, Chairperson of ICOG, Dr. Sheila Mane, Vice Chairperson ICOG, and Dr. Madhuri Patel, Secretary General FOGSI and Editor-in-Chief of Jogi, and Dr. Parag Biniwala, Chair-elect. Uh, with all your cooperation and support, we are able to run this program. And thank you very much for all these efforts. And I'm also thankful to my ICOG Governing Council members for their continuous support and coordination. Before I start further, I would request Dr. Parag Biniwala, Dr. Chair-elect of ICOG, who has been kind enough to join today, and he has spared valuable time from his busy schedule. So I request him to say a few words.
Thank you, Dr. Ashok. Good morning, all. I bring greetings from ICOG, and it's indeed a pleasure to connect with the postgraduates yet again on another episode of PG Clinics. I must appreciate the efforts of the entire team. This program is a brainchild of Dr. Ashok Kumar, ably supported by Dr. Ashish Mukhopadhyay and Dr. Hafizur Rahman, with the sole purpose to educate our postgraduate students and give them an opportunity to present cases in front of examiners from other areas. So I'm sure it's going to be a good learning experience. We've been conducting this program through ICOG for last almost 2.5 years with a lot of success. And I hope that we'll continue it even further so that our young budding OBGYN specialists are benefited immensely. My best wishes for today's program and happy learning to everyone.
Thank you, Dr. Parag sir, for your support and coordination for all these years. And I hope we will continue to have your support in future also. And we are looking forward for your tenure in next year as a chair of ICOG. So thank you very much. Now we start. In the outset, I would like to welcome today my all faculty, Dr. Harish Tosi sir. He is professor and HOD of GCS Medical College, Ahmedabad. And today he will be demonstrating the occipital posterior. This time we have added this series of pelvis, skull, and all other demonstration, which are there important component in the exam as a in the viva. So, and obviously to understand the subject also, these are very important for labor procedures and everything. So we have added this section, and today we will be talking on or demonstrating occipital-posterior position. Then we have case discussion from CCS College of OBGYN and Child Health, Kolkata, West Bengal. And we will discussing the case of benign ovarian mass. Uh, and we have student Dr. Tamal Das and Dr. Sulagna Biswas. And we have very eminent faculty also, this time from different parts of the country. Obviously, Dr. Ashish Mukhopadhyay is always there. And we have Dr. Asha Nirvi. She is professor and HOD from Dharwad, Karnataka. Dr. Meena Emro, professor and HOD from Government Medical College, Rangnadan, Chhattisgarh. And Dr. Lata, she is associate professor from Gangtok, Sikkim. And in the end, I will be demonstrating another section which we have added, how to do it. So last time we have done IUCD insertion. So today we will be talking how to do obstetric exam, which is a very basic thing. And we will falter. And the exam, this has, we all expect the student to demonstrate the obstetric examination on a patient. And we all observe from different corners of the bed and try to see how accurately and perfectly the student is performing this exercise. So this we will be doing in the end. So before we start, I again thanks all my faculty and all participants, all students who are here today. And I wish all of you happy learning. And I hand over to Dr. Hafizur Rahman for further proceedings. Dr. Hafiz, if you are here. Oh, I feel probably he's disconnected. So, Dr. Ashish sir, you can start and say a few words, and then we can start with Dr. Doshi sir.
Yes. Thank you, Dr. Ashok Kumar. Thank you very much. So the PG clinic is progressing, and it's 2.5 years long. We have been doing this program, and we are constantly thinking and evolving new ideas in making the examinee a very comfortable. You cannot make them absolutely comfortable, but we can try and make them comfortable during examination. At least there should not be any kind of fear or nervousness during examination. That element we want to reduce. Knowledge is a different thing, skill is a different thing. So we would like to introduce some of the basic skills which the examiners always want to see in a candidate appearing at the MS terminal examination. With that idea, we have been introducing these things. We'll be thinking more and more, and we'll bring in more and more innovative ideas how to help a student during examination. So with that, I would like to call upon our respected Professor Dr. Haresh Doshi to begin the session, set the ball rolling with his presentation with the dummy doll, the malposition, that means occipito-posterior position. Dr. Doshi, all of you know Dr. Doshi. He is the professor and head of GCS Medical College, Gujarat, Ahmedabad. And he's a very renowned teacher, very active member of the ICOG Governing Council, and we have been always academically enriched by Dr. Doshi in different programs of ICOG, the society programs, FOGSI programs. He has been a very keen faculty of OBGYN, and he also has written a book, and I believe that book is very popular among the students, and I think that he will be able to. We would like to hear from you, Dr. Doshi, about how a student should demonstrate the malposition, that is occipito-posterior. The floor is yours, Dr. Doshi, please.
Yes, sir. Good morning, Dr. Doshi. Please unmute yourself. And may I remind all of you that all these programs are recorded and they are available on ICOG websites. And you can go back and look on the previous PG clinics also on the ICOG websites in different under the pull down menu of different years. So it will be easy for you to understand what all we have discussed, and you can revise your critical points. So,
Right.
Dr. Doshi sir, please.
Yes, I have to do share screen? No. Hello? Hello?
If you have any presentation, sir, then you have to...
No presentation. Baby pelvis. Straight away.
Okay. No, I think you can go directly because there is no need to share screen.
But you are seen on my laptop. I am not seen. Ask tech support.
Okay.
You just go ahead with your demonstration.
Our host, Mr. Biswas, please pin Dr. Doshi, and he should be only visible on the screen.
I think my name is not changed. It is tech support.
No, they have
it is there, sir. It is there.
It is.
Okay.
Mr. Biswas, please pin him down. I will pin him. Okay. No. So now you're on the big screen. Is it right or not?
No, I am not seeing my face.
You are seen, sir. You are seen, sir.
You are seeing, it is right, but if I see my face, it will be better. Oh, should I make the view change? View speaker I have kept.
Yes, sir. You have to
Haresh,
go on a speaker.
Haresh, sir, you can go to your. Yes, sir. You can see your screen visibility option, and you can select yourself. Then it will come in your screen.
No. So self view. ऐसा करूँ? Self view.
Yes, sir.
No, but I should be seen on my screen. No. Full screen
Sir,
full screen.
Can you see the
I am
icon?
there.
Yeah, you
Sir,
can see.
no, I am now in a. But that is
You
it's
please
okay.
continue.
This was small.
Yeah, you please continue. We are able to see properly. Yes.
Okay.
Only thing I request you have to lift the baby little bit up. Yes, yes.
Yes. Okay, now I am there. Very good. Thank you, tech support man. Uh, Good morning, everybody. And I must thank all the FOGSI office bearers, ICOG office bearers, and all other faculties, and particularly the coordinators, Dr. Ashish Kumar, Ashish Ukopadhyay, Ashok Kumar, and Hafizur for inviting me this PG clinics. It is going wonderful, as Ashish told, 2.5 years. Straight away going to the mechanism, last two lectures, Kunal, Dr. nicely demonstrated pelvis, baby, and normal labor. Now we go to occipital posterior. Occipital posterior, I start my clinics in UG and PGs. I ask them which are the three most difficult presentation in obstetrics. The answer comes shoulder presentation, breech presentation. I tell them no, it is occipital posterior, and occipital posterior. Even though it is not a mal presentation, it is a mal position. But it can cause many of problems during labor, active labor, second stage of labor, than all the race put together. We have two positions, V3 and V4. Right occipital posterior is right when the occiput lies in the right quadrant of the right posterior quadrant of the maternal pelvis. It is ROP. When it is on the left posterior quadrant of the maternal pelvis, it is LOP. Okay. ROP is 5 times more common than LOP. The reason is in the left posterior quadrant, there is a sigmoid colon, which is at times filled up with the fecal matter, does not give space for the occiput to come.
Can you pull down your screen so that your lower part also is visible, because your roof is visible. Yes, now it is all right. Yes,
Okay. Very good.
a little bit more, little bit more.
Okay. Well.
Yes, sir.
Fine. Yes.
Yes, sir.
Now it's okay.
Yes. Fine. So ROP is 5 times more common than LOP. The mechanism starts with engagement. Engagement again, like it is vertex. So when the BPD crosses the inlet, I will demonstrate the right occipital, right occipital posterior. And the BPD here crosses the inlet, it is engagement. Here there is some difference from vertex anterior because sacral promontory is there, the neck is slightly extended. We call it deflexate. So the diameter of engagement from the baby side is suboccipitofrontal, middle part of the frontal bone, or occipitofrontal. It is more than suboccipitopragmatic of the vertex anterior position. It is either 10 centimeters suboccipitofrontal or it is occipitofrontal. It is 11.25 centimeter. So this is the right engaging diameter. As you know, in vertex anterior, head engages in the opposite oblique diameter, but in all posterior right and left, head engages in the same. So in ROP, for pelvis, it is a right oblique diameter, the head engages. For LOP, it is left oblique diameter, the head engages. Now, what happens in the mechanism in 90% of the cases, they turn long internal rotation and delivered as it is like occipital anterior. So what happens in mechanism said that first the engagement occurs, may be delayed. Then with contraction, the head descends, flexion occurs. As the flexion occurs, in a 90% of the cases, the head rotates right. Okay, 3/8 of a circle anteriorly, 3/8 of a circle anteriorly. I can adjust my screen that again so that there is no problem. Okay, now I think I should be able to. Okay, now in that position, when the head rotates in a 3/8 of a circle, the neck cannot undergo that much torsion, and that's why what happens is the body also rotates, shoulder also rotates 2/8 of a circle. So this is there, right? I can show you the pelvis only. That will be better. So that right when right occipital posterior 3/8 of a circle it rotates, the shoulder rotates 2/8 of a circle. So it is now converted as if like to begin with of right occipital anterior. Now further internal rotation occurs to bring the sagittal suture in the midline. Then head delivers by crowning occurs, then head delivers by extension. And because there is only 1/8 circle remaining, the restitution occurs in the same position, right, same direction, right side. That's all. The external rotation occurs afterwards, and then the baby it is as straight as or as similar to right occipital anterior. If I show same thing, left occipital posterior, the left occipital posterior, the head engages in the left oblique diameter of the pelvis, the head rotates the 8th of a circle in a favorable condition, the baby rotates in a 2/8 of a circle. So what happens? It is again like converted into LOA position. Now, in this LOA position, 1/8 of a circle remaining with the internal rotation, with flexion, with descent, and then crowning, then delivery by extension, restitution, and external rotation. So in 90% of the cases, this happens that it is converted into anterior position only with long internal rotation. That is a mechanism, right, for 90% of the cases. Now, mechanism in rest of the cases, in unusual cases with severe deflection or when the shape of the pelvis is enteroid or anthropoid, it may rotate right posteriorly going to the sacrum and then delivers as phase 2 pubis. What happens in phase 2 pubis delivery? At the root of the nose glabella, head fixes under the right symphysis pubis, and then first the posterior part delivers by flexion and the anterior part delivers by extension. So it is phase 2 pubis delivery in total occipitosacral, provided there are good contraction, average size baby, and pelvis is either anthropoid or roomy gynecoid. Then and then this type of right delivery is possible with this mechanism. Now, in the 10% of the cases, there are problems. There is no internal rotation. The failure of internal rotation can be due to many reasons. It can be due to deflection, weak uterine action, poor pelvic floor, pelvic borderline pelvis, or some pelvic problem, and these are the premature rupture of membranes. So passage, passenger, and power. If the passage like pelvis is not good, if the soft tissue passage like pelvic floor is relaxed, or baby passenger when the head is large, or when there is a deflection, there is a problem, and weak uterine action either to begin with or due to because of malalignment of the axis of fetal axis pressure, there is a problem. So this all can cause internal rotation. I will explain the 3 types of arrest which can happen. 3 types of arrest, that is deep transverse arrest, oblique occipital posterior arrest, or occipital sacral arrest, posterior rotation and sacral arrest. 3 types: deep transverse arrest, oblique arrest, or you can say occipital sacral arrest. All these 3 are called arrested occipital posterior or persistent occipital posterior. Just on one cause like deflection, I can explain how it happens. Mild deflection. Now, with the labor progressing, the head descends, still the occiput is right slightly lower than the sinciput. So whatever part touches the pelvic floor first will be guided downward, forward, and medially. While it is being guided, at some time the sinciput also touches. So both sinciput and occiput touches the pelvic floor simultaneously, and this leads to not allowing any other पहले आप जैसी बात हो गई. So this not allowing anyone to go forward. So it remains in right transverse position and gets arrested. There are criteria that you will take in management. What are the criteria? With moderate deflection, both are at the same level, sinciput and occiput. and both touching the pelvic floor simultaneously. And because of this reason, there is no rotation happening. It's stuck at that level and it is oblique or persistent occipitoposterior with severe deflection. Now the chin, the sinciput, I mean not chin, the sinciput touches the pelvic floor first. It will be guided forward because the gutter-like floor slope of the pelvic floor is like downward, forward, and medially. Whichever structure touches it first will be guided downward, forward, and medially. And in that situation, now the sinciput goes anteriorly and it becomes a occipitosacral arrest. Occiput is going to the sacrum midline. Right? So these three arrests are sometimes totally combinedly called as persistent occipitoposterior. I told you how to define this arrest. Like for deep transverse arrest, I tell you there are 5 criteria. Head should be in the transverse diameter at 0 station in second stage of labor, fully dilated cervix. Half an hour to some authority says 1 hour arrest. There is no rotation, no descent, and good uterine contraction. Again, 5 criteria. So for deep transverse arrest, transverse position, right? Second stage of labor, half an hour to 1 hour, 0 or below 0 station, and right, good uterine contraction. Same criteria for oblique occipitoposterior or occipitosacral position. So in this, the dystocia occurs, baby cannot deliver, the baby gets jammed, and you have to do some intervention. So that is the mechanism in right occipitoposterior. One in the long internal rotation, which happens normally 90% of the cases. I must tell you that very rarely what happens that baby rotates 3/8 of a circle and the baby is premature or dead, shoulder may not rotate. And what happens is when the head delivers by extension, restitution occurs 3/8 of a circle posteriorly because that was torsion of the neck. And that happens only rarely in a premature baby or a dead baby. Otherwise, always shoulder rotates with the head because in a normal baby, that much torsion is not allowed. Now, in that condition, when 3/8 of a circle goes posteriorly, restitution 1/8, I mean, the external rotation covers happens in opposite direction to restitution naturally. So, and then the rest of the delivery is by shoulder and trunks. So that was a vaginal delivery in a favorable conditions with long internal rotation, all converted into anterior positions, very rarely short posterior position and occipitosacral, right? Phase 2 pubis delivery, phase 2 pubis delivery, and very, very rarely 3/8 of a circle, again rotation happens, but with torsion of the neck, right, the problem occurs that, right, the baby can deliver, but the 3/8 of a circle restitution occurs. This is only possible in a premature or a dead baby. So I think that is for mechanism of labor. And now we should go for the management. The theory part I was told not to discuss. This is given in the book. Only for demonstration it is there. But in management, some theory will come. So what are the principles of management of occipitoposterior? First of all, diagnose it correctly. Nowadays, if you have a doubt in abdominal examination or vaginal examination, you can take help of the right ultrasonography labor, intrapartum sonography. If you have a doubt, if you are good enough and you can diagnose occipitoposterior, the rest of the principles are remain. So that is there first the correct diagnosis because you anticipate a prolonged labor. Why prolonged labor? Because first stage is prolonged and second stage is prolonged. Why first stage is prolonged? The delayed in engagement of the deflex head. Engagement delayed. Then the axis pressure is transmitted more backward. It is not in align with the axis of the pelvis. So there is wastage of force. There may be premature rupture of membranes, so Lycard drained out, and the membranes are a good dilatation of cervix. So it cannot lead to good uterine contraction and dilatation. And the course of labor is delayed because of weak uterine action itself. So course of first stage of labor, second stage of labor, we know because internal rotation occurs in a second stage of labor. So course of labor in all occipital posterior is prolonged. That's what you keep in mind while dealing with your patients, because you have to counsel, you have to be prepared for yourself, and as well as the counsel, patient and relatives that your labor will be somewhat more prolonged than the other, right, primies or multis, because the back of the baby is posterior. I explain to my patients that the baby has to separate from the mother. When the baby's head is down, that is a vertex presentation, it is good. When the baby's back is anterior, mother's back is posterior. So that they take it easily, and that's they understand. So that's how you can counsel the patient. Now, in first stage of labor, don't allow much patient to move much, and keep her either nil by mouth or liquids orally, because anytime you have to enter in the operative intervention and anesthesia and all that. So that's why, to prevent premature rupture of membranes, why that premature membrane of rupture membrane occurs? Because the head in a deflex is an ovoid shape and not a round shape, so does not fit the cervix properly, and irregular fitting leads to more liquor coming down the right baby's head in the cervix and ballooning out the cervix, and membrane ruptures in first stage of labor. Ideally, it should rupture in a second stage of labor, beginning of second stage of labor. So that is there, and that leads to all this to prevent. If patient is ambulatory, there are more chances of that because of brevity effect. So better keep her lie down, nil by mouth, right? Counsel them for prolonged labor. The rest, first stage management as it is like other patients. Here, epidural analgesia is good if the facility is there, because it helps in a the patient can endure that long labor, because otherwise he gets tired, right? So pain relief is a good thing, and epidural does not prevent internal rotation. It is well proved by science. So epidural analgesia is best. Afterwards, if you require to do operative intervention or cesarean section, it can be done in the same anesthesia. So that's why epidural analgesia. So only that is must, right? It is facilities available. Now, as I told you earlier in mechanism, 90% it will take time, but 90% will go internal rotation, converted into that side of the occipital anterior. Delivery happens as it is normal delivery. Only the time is prolonged. What happens is the arrested occipital posterior, or before that, even delivery occurs phase 2 babies, you have to remember that bulky occiput is coming now posteriorly. So you require to give good episiotomy, otherwise perineal laceration tear will happen. So that is very, very important. Good size episiotomy is must, right, in phase 2 pubis delivery. Now, arrested occipital posterior positions, any type of arrest. Ideally, right, in modern times, because we have less skill of operative deliveries, other operative techniques, cesarean section is the best recourse. Only thing you have to diagnose, you should not jump in early. Wait enough, give first stage of labor, second stage of labor, at least 1 hour time before you stamp it as arrested occipital posterior. So cesarean section, if you see your data in your college or in your surroundings, most of the arrested occipital posterior will be delivered by cesarean section. But you must also, learn, and if, for exam also, it is important what are the all other options. So one is vacuum. So vacuum is a good thing that it does not occupy the side of like forceps blades on the forceps, and that it is on the center of the head. So any object like physics principle can rotate around its axis. So with vacuum you have to apply it correctly and give a moderate traction, and it may rotate with automatically. Auto rotation occurs at pelvic floor, and you can deliver. So vacuum is as such best, but because premature rupture of membranes, because caput, vacuum does not stick nicely in all these occipital posterior and may lead to failure. The second is forceps. Forceps is either a forceps rotation or we rotate it manually, that I will come to later, and then apply the forceps. The rotational forceps like Kilan forceps, right? I have done few, but now I have stopped last almost 2 decades, right? So because it requires skill, and nowadays scissor section being safer, people avoid that, and simple after rotation forceps. Even if it is a 90% case and it has rotated spontaneously, you help the mother that you do forceps delivery because she has had a long time pain. So that is, you can complete the delivery by forceps. But forceps rotation is not right. Forceps rotation is not done in modern obstetrics. It is happening in some parts of the world, but not right much in our country. Okay. Now the third thing, right? Third thing, that is manual rotation of the head. Manual rotation of the head is by three ways: the whole hand method, half hand method, 4 fingers, or right with finger rotation, 2 fingers, right? How it is done, like for, but it requires anesthesia also. So, right, so you have to do it that way. Okay, now it is, I'm sorry, I'm holding in a left occipital posterior position. For left occipital posterior, left hand, right is to be used, introduce it fully, depress that, and then rotate it with also simultaneously helper or right, your second hand rotating for abdomen, the shoulders. So long three, you flex it and then rotate it, rotate it, right, to bring it. Okay, so this is right, you flex it, and then because I'm showing from above, right, it will not be for you to understand. Okay, now I've done that way. Now I'm going in the pelvis, right, and it is right. Now it is left occipital posterior, right occipital posterior, and then I will rotate by right hand. And for left occipital posterior, right, left occipital posterior, right, I will rotate with the left hand. So whatever is your dominant hand, you can change it, but you have to use separate hands for ROP and LOP, right? But for half hand method, it is only one hand, dominant hand you are using. Suppose we are right-handed person, right, and it is right occipital posterior. I will pass my hands posterior to the head and rotate it, and rotate it. Only 4 fingers, 4 fingers, and rotate to bring it anterior, and symphysis pubis. Right. If it is right occipital posterior, again the right hand, but then I will go anterior to the head and rotate it, right? So that is, again, I show outside. If it is left occipital posterior, I, with 4 fingers, right, I go like this and rotate it. If it is right occipital posterior, I go anteriorly. And so you have to bring the occiput in under the symphysis pubis by shortest arc of the circle. If it is LOP, this is the shortest arc. If it is ROP, right, this is the shortest circle. So accordingly, your hand can go posteriorly or anteriorly. In half hand method, you have choice of your dominant hand. But for full hand method, for rotation, you should use your whatever hand is according to position convenient to you, right? So 2 finger rotation. Now this 2 finger rotation, right, it is there. Okay. Now I do that in a deep transverse arrest many times, and I'm successful also, because in deep transverse arrest, that is only right at 3 o'clock occiput, and that you require to do it. Okay, fine. So this 2 finger taking the support of the whatever molding has occurred between the two suture lines, take the hinge on that and gradually rotate again, like per abdomen rotation of the whole of the body. Also, you must do simultaneously. That helps. So 2 finger method, you don't require much anesthesia, and for whole hand method, good grip, but it disimpacts the head. That is a disadvantage. So all three hand techniques have some plus and minus points. or full hand method, half hand method, or two finger method. So these are the manual rotation. But when you have done that, when you have completed that, always apply one blade of forceps so it does not go back, and then you complete the procedure or delivery by forceps. So that is that. For that you must you recourse to this manual rotation and all that when you are comfortable in forceps only. Otherwise, then again there is no sense of doing that rotation because it may go back or it may not be successful. So that is the three other options to cesarean section: vacuum, good, less trauma to the baby or mother rather, uh, and but it is difficult to apply because of caput, and good traction may not be possible with the vacuum. It pops off. Forceps rotation, which is not happening, and Scanjonis maneuver was there. Double application of forceps. It is the first you rotate and then remove the blades, and then you again apply the blades. That is not done. I've never done it. Wandering, the rotational Killian forceps. Very few people can do it. Okay. The third is the manual rotation. Correct it to manually, manually with full hand method, half hand method, two finger rotation, and then apply the forceps and complete the delivery. Right. Very rarely that you may be unlucky and you get either a referred patient, then the baby dies. And the baby dies, nobody would like to do cesarean section on a dead baby. And in that, okay, you always, can do craniotomy. You have not seen it, you may not, want to do it, but it's a very simple procedure. Under local anesthesia, pudendal block, also you can do it, better in spinal, right? But then as soon as you perforate the cranium, the brain tissue comes out and the much molding or collapse of the bones occurs, and delivery becomes easy. Only in a dead baby, not in a live baby. Live baby, as I told you, in present scenario, most of the time the cesarean section, and cesarean section. I think I finished fast, but because of I started late. Dr. Ashish, Dr. Ashok Kumar.
Thank you, Dr. Doshi, for your elaborate and erudite demonstration of occipital posterior, such a difficult topic for the students to understand. And I know that you are not fully fit today, but even then you have participated in this tutorial, which just shows your sincerity and devotion as a teacher. Sir, I pranam to you, sir.
Thank you, sir.
The second point is that I would like to make a few comments on the malposition and malpresentation. And I think because we have to done in time, should I take it after this thing, or we can take it right now? If I take it now, then we can spare Dr. Harish Doshi, because he is not liking to participate in the case discussion. Only for that purpose, I'm just making the comment.
Sir, we have 10 minutes. We have 10 minutes. We can do it. We can do it.
Okay. So first of all, sir, I would like to explain it to the students, or rather describe to the students how to do an abdominal examination diagnosis of occipito-posterior. Malposition, abdominal diagnosis, I think the students should learn, sir. Where is the location of the back and where is the location of the fetal heart sound? They should, as it is, they are clinically becoming very poor these days. So these are the points I would like to mention to them. Second is, see the terminology, I'm sure I'm having an open discussion with the faculty members. Term persistent occipito-posterior. Many examiners, many of our friends, they feel that it is only the occipitosacral position is the persistent occipito-posterior. But according to Dr. Doshi, you have mentioned that all three are persistent occipito-posterior. All the results of the malrotation are persistent occipito-posterior. So I think the students, you have to be properly explained about these things, because this may create confusion, because many of the examiners, I have seen that during the course of taking examination, they feel that persistent occipito-posterior means occipitosacral. Sir, I'll just finish in 2 minutes. Then any arrest in obstetrics, the definition is the same. As you said correctly, sir, you have particularly mentioned in case of deep transverse arrest, but any arrest in obstetrics means the presence of full cervical dilatation Second stage of labor, engaged head or engaged presenting part, no progress of labor after up to 1 hour. So this is a standard definition of arrest. And deep transverse arrest is no exception. Only thing is that the students can scan these 3 words, deep, transverse, and arrest. Deep means the head is engaged. So head has to be engaged. Deep transverse arrest is not possible in a floating head or unengaged head, number 1. Number 2, sagittal sutures in the transverse disposition, 15 degree you may allow. And arrest means, as I said, the definition of arrest is no progress of labor despite having good contraction in and after 1 hour of full dilatation. So that is the standard definition. I think students are frequently asked to give a short note on the deep transverse arrest, so they should know it properly. And what is the level of the arrest, they also should know. Now, you have mentioned about counseling, sir. A frequent question by the patient and her relatives is that because you said that there will be delay, they will always ask how much delay, because labor is it's quite an enigma to them. Nowadays, we are allowing one companion with the labor. According to the new labor room protocol, we're allowing a companion. There's also an usher worker there. But I think still, because they do not know about the malposition and malpresentation, we haven't been able to educate them that way. That much of depth of education hasn't taken place. So therefore, I would like to say a simple answer to this kind of a question. Suppose the PGT faces this question. There will be delay. Why delay? You have explained. There are 3 reasons of delay. 1 is delay in engagement. Second is delay in internal rotation. And third is delay in the passage of the baby. Now, the how much delay is the question. I think we should say that 3 times the normal time that we expect, because there is 3/8 of an internal rotation. You can explain this way. So that is my suggestion, what the students can think. And third thing you have mentioned, sir, that in particularly occipito-posterior, which is such an exhaustive phenomenon, and any malpresentation in any gravida, irrespective of primary gravida, multigravida, patients must have IV fluid. As you have correctly mentioned, IV fluid is a must in cases of all occipito-posterior in labor or any malposition in labor. Now, for last point I'd like to mention here before I give up is that the manual rotation requires great degree of depth of anesthesia by a very senior obstetrician and pediatrician, and that too, the rotation has to be done by a very experienced person like Professor Doshi in between contraction. I think that even if you have given anesthesia, people might argue that, okay, I've given anesthesia, but that doesn't quieten the uterine contraction. So I think you have to do it in between contraction, and that you have to take special care of. So I submit before you, sir. Now you can say.
Thank you, sir. Thank you for appreciating, because I was running fever 2 days back only.
I know.
Because it is my favorite topic. I could not resist.
Sir, one polite suggestion, sir. You should have taken one assistant, sir, because that also carries a message to the PGTs that in any management of abnormal labor or malposition, you need an assistant. Okay.
Yes. Diagnosis I omitted because I was told straight away that you have to start with the mechanism of labor.
That's one point, sir.
Otherwise, your point is correct that perabdominal examination, the flat, suprapubic flattening, the limbs on both sides, anterior shoulder far lateral, FHS difficult to locate, and these are the clinical points. The most important point is your false impression of the engaged head, because it is occipito-posterior. What happens, sir, that this is you are filling the chin part of the ear, chin part, and then you think that it's engaged, but when you do PV, it is still -2, right? Because it is the small part of the head is anterior, so that is a problem. Then you told clearly that the persistent occipito-posterior. See, sir, I told you there are 2 things: deep transverse arrest, occipitosacral arrest. But the whole 90-degree quadrant is oblique occipital. There is no oblique definition as 45 oblique. So that's why the people are now using that. Why to have that 2 landmarks mix up with this is better. So all are correctly told as persistent occipito-posterior. It may be lateral and it may be sagittal suture posterior. And you rightly mentioned that counseling is, I got a new point from you, that 3 times, 3 internal rotation happening. So that is our. Thank you, sir. Thank you.
Thank you so much. It was wonderful. Dr. Ashok Kumar, would you like to comment on this demonstration before you go to the case?
Hello, Dr. Ashish. I think Dr. Harish has given an excellent presentation.
Yeah, yeah,
No?
Just
yeah.
1 minute.
Yeah.
I welcome now Dr. Sheila Mane, madam. Yes.
Yeah.
I think the
First of all, two things, madam, we want from you. One is comments regarding Dr. Doshi. Any comments on that, President? But before that, we welcome you to this FOGSI ICOG PG
Yes, yes.
clinics and to say few words.
As a welcome.
yeah, thank you. I must thank you, all of you, for very sincerely and with so much of dedication doing this. I was listening to Dr. Haresh, and he is really demonstrated it so well. I think students sitting in every corner of the country are benefited on a Sunday, and the other additions or doubts Dr. Ashish Mukherjee told about that. I think that is very important, that first of all, they should have a doubt when they are doing a per-abdominal examination that this could be a occipito-posterior position. Even the location of the fetal heart itself will give you a doubt. When you find it really difficult when the back is posterior, or when you find it in the midline because the chest is pressing in front. So these are the very clinical points, I think, which is very helpful. Now, in fact, one step ahead, there is an ultrasound in labor.
Labor.
Okay. And those who have the facility can, but I think the clinical suspicion, the
Yes.
progress of labor itself will tell you that there is a malposition. And I congratulate Dr. Haresh Doshi for demonstrating it so well. I must tell you, Dr. Haresh, that the people, those who have passed and those who are consultant now, still remember your classes. Oh, I have attended first classes. Okay. So those,
Thank
they
you,
are
madam.
the teachers now. Now you are a teacher of the teachers today. Okay.
Thank you, madam.
Thank you.
Just
Thank you.
half a minute, Ashok Kumar. That madam rightly pointed out, right? FHS also tells you. Same way, the progress of labor also tells my students when sonography we are not using in labor room, that if the patient is not progressing well, you can doubt comes in. It may be occipito-posterior. You have missed it, and that is in that sense it is important. So thank you, madam. Thank you for nice words.
Thank you,
Sir,
Dr.
there is
Sheila Mane and Dr. Doshi. Dr.
one
Ashok Kumar.
question. Sir,
Yeah.
1 minute. There is one question from the our audience. Where to do craniotomy? Please suggest points for PGs.
Craniotomy, as I told you, now is happening very late because we are doing liberal cesarean section. But still, in a medical college, we get a patient which have been given trial, and when they reach to institute, their FHS are not there. So, in that, the basic requirement of any destructive operation is not a absolutely contracted pelvis. It may be borderline pelvis and all that because of deflection and all that, the labor and dystocia occurred. But then that occurred, you have to judge it that it should be zero station again, zero or plus. Caput molding will tell you wrong things. You catch the two right under, put under block or better spinal anesthesia, two scalp which is protruding because of caput, and put a cut with the scissor, and with the, because now craniotomy may not be available in any institute. And with the same scissor we poked in, and we better go either it is said that better to perforate the bone, but not required. I have hardly perforated, but better you separate the suture lines, which is now giving way easily with your scissors. You open it transversely, rotate it, and open it vertically. That opening is sufficient. With a so compressed head in the pelvis jam, the brain matter comes out like anything. And when the brain matters comes out, you catch the alleys with long alleys, the scalp, which was your cut, caput, the hairy scalp, and then you can pull out easily. Sometimes it becomes so easy, unless there is a very big baby and all that. So because it was a problem of dystocia related to many things, but when the decompression, size decompression occurs, the delivery happens early. I mean, easily.
Thank you, sir.
Now, anyway, forceps, one addition, Dr. Ashok Kumar.
Yes, madam.
Some people used to prefer even just put the forceps and to make it steady and then do the craniotomy. But now, as we are not going higher ups, okay, you are not going to extract the baby with the forceps, just to make the presenting part steady and then do the craniotomy was tried in the past.
Thank you, madam.
Thank you.
So we close this section and we will start with, thank you, Dr. Haresh Doshi, sir. And we start now with case presentation. and case discussion. The case is on benign ovarian mass, and we have students from CSS College of OBGYN and Child Health, Calcutta. And the students are Dr. Tamal Das and Dr. Sulagna Biswas. And Dr. Chakravarti is the coordinating faculty from the institute. And I now welcome all my expert faculty, Dr. Asha, Dr. Meena, Dr. Lata, and Dr. Ashish sir, to start the proceedings.
Okay. Thank you, sir. And I would like to call the students, Dr. Tamal Das and Dr. Shulagna. Say hi and good afternoon to everyone.
Good afternoon, everyone.
And share your screen. Yeah.
Please share your screen and start presentation.
And thank you, Dr. Jyoti Jaiswal, for your question. And I hope Dr. Doshi has given the satisfactory reply to your question on craniotomy. Thank you very much.
Yes, start. Who is going to present first? Then Dr. Tamal Das, isn't it? Okay.
Yes, sir.
Please start.
With regards, Dr. Jaideep Tang, Dr. Parul Kotawala, Chairperson ICOG, Dr. Sheila Mane, Vice Chairperson ICOG, Dr. Madhuri Patel, Secretary General FOGSI and Editor-in-Chief Jogi, Dr. Sharita Valedau, Secretary ICOG, and coordinators, Dr. Ashok Kumar, Dr. Ashish Kumar Mukhopadhyay, and Dr. Hafizur Rahman, and Dr. Shivle Chandra Chakraborty. I am Dr. Tamal Das, and with me, Dr. Shulagna Biswas, third-year resident from CSS Kolkata. We are going to present a case. Patient's name is Mrs. S.D., 32 years, para 2+1. She is homemaker. She resides 12 kilometers away from our hospital. According to modified Kupuswamy scale, she belongs to lower middle class. She presented with heaviness in the lower abdomen for last 1 year and lower abdominal pain for last 2 months. Patient has been experiencing a gradual onset heaviness in lower abdomen for last 1 year. She developed pain in the lower abdomen since last 2 months. This was over and above her pain during menstruation. Pain was dull, aching in nature, occurred occasionally, did not spread to adjacent areas, and was relieved by medications. No history of dysuria, dyspareunia, and dyschezia or white discharge per vaginally. No history of postcoital bleeding or any mass coming out per vagina. On 2 occasions during last 2 months, her pain became severe and she consulted local physician who prescribed medications. Finally, she was referred to our hospital when pain continued despite medications. Her menstrual history was essentially normal with duration of flow 2 to 3 days with moderate flow, and she needed 3 to 4 pads per day, no nighttime changes of pad and no clots. Her cycle was regular. She complained about cramping pain during menstruation, though this pain was not heavy and severe, but disturbing her daily household works. Typically, the menstrual pain started 2 to 3 days before and continued through the menses. Her obstetric history was uneventful. She delivered 2 baby vaginally and 1 MTP done at our hospital. There was no history suggestive of major illness and no history of hospitalization or blood transfusion or surgery in the past, and no history of tubectomy. There was no family history of twin, tuberculosis, diabetes mellitus, and hypertension, asthma, or cancer of breast, ovary, colon, and endometrium. Patient has no history of allergy of inhalation, ingestion, or contact, except allergy to sulfur-containing drugs. There was no history of addiction. Her sleep, thirst, bladder history was normal. Appetite initially poor, but regained later. Bowel habit occasionally constipated. She consumed mefenamic acid and tranexamic acid combination for 2 weeks in the past, and There was no regular contraceptive use except occasional use of condoms. Essentially, she has a non-veg diet, but also contain vegetables and milk. Components of daily diet were balanced and mixed. Her calorie intake is 1800 kilocalorie per day, and protein intake is 62 gram per day. There was no significant calorie deficit and protein deficit. From now on, Dr. Shulagna will continue.
So, can you summarize, Tamal, your history? Hello, just
Yes,
summarize history.
Yes, ma'am. Mrs. SD, 32 years, para 2+1, living issue 2. Last childbirth 11 years ago, both vaginal deliveries at our hospital, and also with the history of MTP 5 years ago, belonging to a lower middle class family, and staying approximately 12 kilometers from our hospital, was admitted through OPD of our institution with the complaints of lower abdominal pain.
He has pain abdomen, no? Pain abdomen and
Yes, heaviness in the lower abdomen for last 1 year.
With the dysmenorrhea, no, isn't it?
Also,
Right. So what, can you give one word for the symptoms, like one word, what we call? Have you heard of chronic pelvic pain?
Yes, ma'am.
Yeah, you can call this symptomatology as a
Chronic
pelvic pain, isn't it? Okay, and your family history, when you know that this is a chronic pelvic pain, in a family history, you could have added one more, this one, history. Can you add now, or can you suggest what you can ask in family history? Or what are the causes for chronic pelvic pain? Can you mention?
History of tuberculosis or PID.
Okay, pelvic inflammatory disease. What else? You thought of endometriosis, isn't it?
Yes.
It can also cause
Chronic
pelvic
pelvic
pain, isn't it? Fibroid, any pelvic masses, they all cause chronic pelvic pain. And does the endometriosis run in the family?
No, ma'am. There was no history of endometriosis.
No, but it
Runs.
isn't it?
It runs in the family, you say.
Yeah. It runs in the family. There is 7 times, if sibling is suffering from endometriosis, or any daughter, there are 7 times more chances of a person getting the endometriosis. So there is definitely a role of family history. Okay, that you should add, I think. Otherwise, all right. So in a nutshell, you are dealing with a case of a chronic pelvic pain, isn't it?
Yes, ma'am.
Okay. All right.
Just I'd like to add a few lines to this, Dr. Asha.
Yes, sir.
This pain is actually, the patient presented pain for 2 months. Am I right, Dr. Tamal?
Yes, sir.
It was a late onset, and she used to feel heaviness for last 1 year. Unless and until the pain, usually in our practice, what we do, the pain is of some duration, like for instance 6 months or something like that.
6 months at least, yes.
We do not call it as a chronic pelvic pain. Anyhow, it is going to be chronic pelvic pain. Yes, of course, we can say that the PGT should think about it beforehand. Yes, that's okay. But making a diagnosis of chronic pelvic pain in
duration is 6 months, at least minimum 6. You are right, sir.
Yeah. So continue, Shulagna, with the next part. Go back to the slide. Yes.
Yes.
General survey. She is conscious, alert, and oriented to time, place, person. She appears normal, weight 60 kgs, height 5 feet 2 inches. Her BMI was 24.2 kg per meter square, average build. Her pulse was normovolumic, regular, and she was normotensive. And respiration 18 per minute, thoraco-abdominal. Mild pallor was present, but there was no ictera, cyanosis, clubbing, edema. Neck veins, including thyroid, not endorsed, and neck glands are not palpable. Supraclavicular and inguinal lymph nodes are not palpable. Breast examination, no encouragement, no venous prominence, or any nipple areola complex was healthy. Abdominal examination. On inspection, abdomen was scaphoid, slight fullness seen at suprapubic area, but no venous prominence or any scar mark. On palpation, abdomen was soft, no lump palpable, no ascites or any shifting dullness. There was no tenderness and no hepatosplenomegaly. There was dull on percussion and on auscultation, intestinal peristaltic sound were present. Local examination. Inspection. On inspection, vulva and perineum look healthy. There was no skin lesion, no vaginal discharge or any prolapse. Past speculum examination, cervix and vagina healthy. There was no cervical tear or any discharge, growth, cyst, polyp were seen. Bimanual examination. Uterus was 6 weeks in size, retroverted, first degree, mobility was restricted. A mass fell through left fornix, approximately 2 inches by 1.5 inches in size. That was cystic in field and group sign was present. The movement of cervix was not transmitted to the mass in the fornix. There was no lump palpable in right fornix and it was non-tender. No mass or any nodules felt in pouch of Douglas. Per rectal examination, normal smooth rectal mucosa felt and no nodules. The summary of general survey and examination. On general examination, she was alert, cooperative, oriented, of average build, weight, height proportion. She has mild pallor, normal pulse, and normotensive. No abnormality detected in her systemic examination. Past history, family history, and personal history were unremarkable. On abdominal examination, suprapubic bulge is visible but no palpable lump. By bimanual examination, uterus is bulky with mobility restricted. A sizable mass fell through left fornix and it is separate from uterus, non-tender, cystic in field with compromised mobility. No nodules in pouch of Douglas were felt and parectal examination was uninformative. The provisional diagnosis was 32 years, para 2+1 with left-sided moderate size cystic ovarian mass.
Dr. Sulagna, I have one question. One side you said that uterine size is 6 centimeter around, and one other side you are saying it's bulky. So you have to correct it. It's not bulky. It's a you can say multipara size instead of saying bulky. I think so. 6 ways. What is the size of uterus? It's a very very simple question. So 6 weeks is a little.
6 weeks in normal size.
Dr. Ashish?
Yes.
It's normal
Yeah,
size.
actually,
So it's multipara.
normal uterine size is 5 centimeter, but 6 centimeter, you should not call it bulky. It is just multiparous. Yes, you're right. Multiparous uterus, 6 weeks is normal.
Sir, I think before we start, we come to the basic. And I hope you all will help me in conveying the message of basic findings which should be mentioned for all the students, because these are the parts of the examination where we always note of these things. In routine practice, you may not be using all these. That's all different thing. But basic things what we have to, so stay at this pelvic examination.
Pelvic examination.
Don't change that slide. Yes, local examination. So, Dr. Ashish sir, I need your comments also there. Inspection per speculum, all right. Bimanual examination. What is this bimanual examination, my dear friends? This is bimanual where? Bimanual examination of office. So you have to complete everything. It is a bimanual pelvic examination, or you say it is a PV examination. Right? So PV examination starts with cervix.
Yes.
Where is cervix? You have not felt cervix in this examination?
Yes.
So that is what we want to highlight. But these are the basic things. We have to start with cervix, and it is direction, position, and consistency, regularity. Everything you have to mention when you are palpating. You are palpating the cervix first of all with your 2 fingers. So you have to mention that. Then the second part you feel is the uterus. Uterus, you are saying bulky or normal size, but you're writing as 6 weeks. 6 weeks is a large uterus. So you have to justify all these things. You cannot be very casual in findings, basically. And you have not mentioned anything about the uterus whether it is what is the consistency of the
Consistency.
uterus, what is the whether it is regular, smooth surface. You're right, retroverted, that's all right. But what about other things? It is a very incomplete PV examination.
For example, you can write cervix is multi.
Upwards.
Sorry.
Cervix upwards. It's retroverted uterus.
Cervix upward
And,
and os external
yeah.
multiparous or slit.
I think
Transverse.
Dr. Ashok Kumar is mentioning.
And then in the
about
mass, and in the mass, you are saying it is felt through left fornix. You mentioned the size. You mentioned the consistency, specific in feel. You mentioned about the groove also. You mentioned movement of the cervix is not transmitted. But what about the tender? Whether tenderness is there in the mass or not? See, when we describe anything, if you have to read, das we used to read for surgery, basic thing. So how to describe a swelling, how to describe a mass, these are all there in Bailey Love also. So you have to see that your all components are mentioned.
Yeah.
There's so many things which are missing here.
Yeah, I think, yes, Dr. Ashok Kumar, I agree with you on almost all the points. Bimanual examination in simple terms, it means you're using two hands. But you can use your two hands everywhere. You can do a chest
Everywhere.
examination.
Yes, yes.
You can use abdominal examination. You can have rectal examination, etc. So it is very specifically, it should be mentioned bimanual pelvic
examination.
So that is the one point well taken, sir. Thank you. The second point is that they have described the cervix through the speculum examination only. That means the vision. But yes, it is very correct to palpate the cervix also for any irregularity, the feeling of the cervix. From undergraduate days, we have been teaching what is the difference between a pregnant cervix and a non-pregnant cervix. So I think that feeling the cervix is also important and it has to be noted there. Coming to the mass, yes, 2 inches into 1.5 inches is stick in field and group sign is there. Movement of cervix is not transmitted. That is all right. It looked okay to me, except the tenderness. Yes, of course. They mentioned about tenderness in the right fornix and in the left fornix. While describing the lump, they didn't mention the tenderness. Yeah, mass can be tender also. That is true. Even if the patient doesn't complain of any pain, still the mass can be tender. So you have to mention that. And Baki, these 2 points have to be corrected. So kindly note that. Yes, Dr. Ashok Kumar, anything else, sir?
Yes, sir. I think these things should be noted down by all, and one should be careful about mentioning these findings because we are we have to complete. So my only one statement, which I always give it to my students also, that we are the gynecologists. No one else will do the PS and PV examination. Only we have to do it. So if any patient comes, if we are not doing it, then don't expect anyone else done this, and we will miss the findings.
Correct. Correct. So,
I want to ask one question. Like Sulogra has mentioned that there is a groove sign, isn't it? What does it suggest? Like, what do you think? What is your comment on that?
A groove is present in between uterus and the adnexal mass.
So the mass is not arising from the uterus, you mean?
Yes.
Yeah, that is very important. And
Yes.
also cervical movements are not transmitted to the
mass. Movement of the mass. It also suggests it is not in uterine masses.
Yes. Any other findings? Like, if it is a mass in the because of endometriosis, the cervix will be pulled towards that side, isn't it? That
Yes,
also you should look during per speculum examination. Okay.
Okay.
Asha madam, you have some water, please.
Yes, sir.
Okay. So now that you have come to a provisional diagnosis, go to the provisional diagnosis. Dr. Ashok Kumar, can we proceed? Provisional diagnosis.
Yes, sir.
Sir, yes, sir. Please.
Okay. Okay. So you are saying 32 years, para 2 plus 1 with left-sided moderate sized cystic ovarian mass. Okay, fine. So what are the points in favor of your diagnosis? And what are the points against your diagnosis? Points favor Palabolo.
You can go to your history. There you have
History se shuru
something. Yeah, history say you can.
History.
She
Age.
she is 32 years. She is in reproductive age group female.
Yes.
And she has plain complaint of heaviness for last 1 year and abdominal pain last 2 months, but there was no menstrual irregularities and no severe dysmenorrhea. And from history, only suggestive of lower abdominal pain and heaviness for last 1 year. And on examination, we find that the uterus is bulky with restricted mobility, and a 2 inches by 1.5 inches lump fell through left fornix that is separated from uterus. That suggests, and it was non-tender and cystic. That lump was non-tender and cystic in feel with compromised mobility. That suggests it is a cystic in nature, and it is a cyst.
So what is your provisional diagnosis?
Cystic is the feel. And why do you say this ovarian mass?
Yes.
Have you ruled out pregnancy also?
Yes.
No contraception, 32 years.
Yes,
No digestion, yes.
her menstrual cycle was essentially regular, and her LMP was last 4th February, and she has a regular menstrual cycle.
I have one question. What pregnancy related you can get a mass in the fornix? Pregnancy related a condition where you can get a mass in the fornix. Can you name one? Though she's not tubectomized.
She's pale. Yes, she's come with pale and pain.
Yes,
It's clear.
madam is giving clue. Yeah,
What is
type of
adnexal mass you
ectopic?
get if she's pregnancy?
Ectopic pregnancy.
Chronic
Come on,
ectopic.
Sulaka.
Chronic ectopic.
Can be a chronic
Chronic
ectopic. Yes, yes. Okay. So your provisional diagnosis
Tamal,
Yes, ma'am.
actually, again, you have written moderate size, and it's as you
Yeah,
mentioned,
it is
size
not
is very
moderate.
small. So it's not moderate. You have to small size. I mean
Okay.
to say it's a small size. Okay, so you have to just check, and you have to, before making provisional diagnosis, you have to correlate all the history, examination, then diagnosis, just to avoid this differences. Otherwise, the examiner will caught you.
So what is your provisional diagnosis, both of you? Provisional diagnosis, like cystic mass. Okay, but still, can you come to some definitive, because she has pain, chronic pain, any condition?
So, Lagna, any conditions she's asking?
Can you suspect
32 years, para 2, cystic ovarian mass.
She is in that reproductive age group. She has
Elaborate
a pain
your
also,
provisional diagnosis. Elaborate.
She has a dysmenorrhea also, no? She has.
It may be endometriotic cyst.
Yeah, endometriotic.
One thing there, madam. Endometriosis. You just first put us endometriosis. To her age, young age, 32 years.
Yes.
Para 2, she has one miscarriage. At this age, do you want me to think about endometriosis? Her fecundity is very good. What do you mean by fecundity? Fecundity, what do you mean by that?
Fecundity, chance of getting pregnant.
Yes, yes.
What is a normal in a reproductive age group person? How much is it? If you don't know the normal, because obviously when you have telling endometriosis, I find it a very good fertility index. Endometriosis, okay, fine. But even though she might come as endometriosis, I'll put it down the diagnosis. Considering her age and para 2, we are facing a lot of endometriosis related infertility now, please.
Yes.
So fecundity will reduce.
Yes.
Find out.
She may not be so fertile. That's what madam wants to say. If you suspect endometriosis, cystic lesion, but mainly because she has pain, abdomen, and dysmenorrhea. So
Yes.
that is one probable diagnosis. What are the other diagnoses you have in your mind?
Other diagnosis may be differential diagnosis or any dermoid cyst or tubo ovarian masses.
How do you rule out endermoid cyst now? If it is dermoid cyst, how in positive PV findings, how is it? Do you get that retroverted, fixed uterus, restricted mobility? Where do you find the dermoid cyst commonly?
Commonly where they are? Yes, madam.
In younger age group.
No, no.
She's young for me. She's quite young for me. 32 is quite young. In clinical examination, how will you differentiate between endometrioma and dermoid?
Dermoid cyst.
Dermoid cyst may be unilateral inside, and there may be
dermoid cyst is not always unilateral.
Not always. It can be
bilateral.
Yes.
Then
and the surface would be irregular or multilocular.
No.
So by clinical examination, we are asking dermoid cyst by clinical exam. Where they are? Location usually.
And you told perabdomen suprapubic fullness also. You told perabdomen suprapubic fullness. So by bimanual pelvic examination, commonly, not necessary always.
Yes, madam. Commonly. Which fornix you can palpate them? Anterior, lateral.
Lateral fornix.
Dermoid.
No.
Usually.
No. Posterior fornix due to retroverted.
No.
I have given clue.
Per abdomen also you told suprapubic.
Yeah.
I am saying. Very commonly, usually they present it like that.
Yes.
Anterior fornix.
Okay. Anterior fornix.
Anterior
fornix, where they will be mobile. Non-tender.
Non-tender, that is.
Non-tender, mobile. Because endometriosis, we have given good clinical findings where I can go for endometriosis. So even though our age and parity doesn't favor it. Anything else, madam? Continue. Why not tubo-ovarian mass? She's good for tubo-ovarian mass.
Yes, there was a history of surgical medical termination of pregnancy and MTP 5 years back at our hospital, and tubo-ovarian mass also difficult to palpate, and there may be same history like heaviness and pain abdomen, and so it may suggest tubo-ovarian mass.
Anything else in the history they can have? They can have a history of fever, sometimes isn't white discharge, copious white discharge, purulent discharge, sometimes fever. Yes,
chronic pelvic pain.
And
even in differential diagnosis, one more thing you should have a functional cyst, which is more common.
Yes, that's
functional ovarian cyst. Yes.
Can you tell what is this functional cyst, Tamal and Lagna? What are this functional cyst? Can you say some few points on this functional cyst?
Functional ovarian cyst are benign ovarian cyst. It found incidentally, and it is its size is generally less than 5 centimeter, and it get reduced by naturally or by oral contraceptive pills. No need.
Not proven. OC pills not proven.
Not proven. Yes, that is the message I think students should know. OC pills are not proven. What is the cause for this functional cyst like? After the ovulation, the follicle should get absorbed, isn't it? It doesn't get and it starts getting distended. No, they can grow up to 7 to 8, isn't it? They can be asymptomatic, but sometimes what complication can happen in this, and then we may have to treat them in functional cyst.
It may
rupture or torsion.
Torsion. It can undergo torsion. Yes, isn't it? Yes. What are the other functional ovarian cysts you know? This is follicular cyst, you said?
Follicular cyst and corpus luteal cyst.
Yes. Then?
Theca lutein cyst.
Theca lutein cyst, isn't it? Theca lutein cyst. They all come under the functional
ovarian cyst.
Yeah. Okay. What will be the ultrasound picture in this functional ovarian cyst?
The cyst may be unilocular cyst, smooth wall cyst.
Yes, unilocular smooth wall.
And there will be no solid component, and there will be no papillary projection or.
Correct.
And no septa. It is small in size, maybe large, but generally it is within 7 centimeters.
What is the cutoff? Like how you the OC pill has no role. So what advice you give to the patient? Like she'll be worried once you say cyst, she will be worried. So how do you counsel her?
I will reassure her
Yes.
that within 5 centimeter, there
No need to
no
any
need to do
surgical
any intervention.
unless
I
she
will
has any symptoms.
So when you
I will
call her
ask
for
her.
again follow-up, you want
Yes,
to just
yes, I will ask her
alone
for
or-
follow-up.
Yeah. You want to repeat the scan?
Yes, after
Yes.
6 months.
Yeah. Yeah. Up to 12 weeks or 3 to 6 months, you have to.
Yes, rescan and see the size. And
Yeah. Suppose the size has increased. What is your, what counseling you'll do?
If it is below 7 centimeter,
no, it has
then
become now 8 to 9 centimeter it has
size
become.
is increasing progressively and patient has any symptoms like pain, then we will offer her for surgical intervention.
Yeah. What is the best option for her?
Cystectomy, ovarian cystectomy.
And she's not tubectomized, so anything else you want to do?
We want to do bilateral self-injector.
If any functional cyst is fast growing, then you have to think about benign or malignant. I mean, malignant, you have to rule out. So, okay, otherwise, yes, you can say the patient to just wait for 4 to 6 months as per guideline. Can we move them
Yes.
towards?
Yes, yeah.
Yes.
For
Yeah,
this
others
lady,
can
now
ask.
how do you proceed? See, you have made a diagnosis, 32-year-old lady, dysmenorrhea, parity, good. She has a pregnancy baby also. Come with adnexal mass. So you know the mass is from the ovarian. Clinically, you are thinking it is from the ovarian. How do you proceed?
Yeah,
Our
before
main
you proceed
complaints.
with the investigations, Dr. Latha and Dr. Asha and Dr. Meena, I'd
Yes,
just like to put in 1 or 2 words here.
Yes, sir,
Is
please.
that adnexal mass palpation by PV or bimanual PV examination is quite a difficult ask, and it requires a lot of practice and experience.
Yes,
And yes, dermoid cyst, the traditional teaching, we are also taught that it comes in the anterior cornix, but we have to also remember that dermoid cysts are perhaps the heaviest tumor in the pelvis and which can go posteriorly also. So I think that the fornicial palpation
Commonly usually
doesn't give you a sacrosanct findings in all cases. And regarding Shulagna's statement that in after 6 to 7 centimeter of size, some people say 5 centimeter. If it is there's a question of rapid growth, which is substantiated by the sonographic examination. Here, the question of the investigations come into play, and you must go for the tumor markers and other investigations like CT scan and all these things. Of course, the presence of other clinical findings like ascites or other system development or any urinary problems, etc., will lead to this thing. But in investigations, it must be done. Everything cannot be done clinically. Yes, Dr. Please proceed to what was your question? Like, how do you proceed now from here?
Yeah. Young lady with an adnexal mass, with a doubtful of ovarian region. Clinically, we can't be 100% confirmative. So how will you confirm now? How will you proceed?
Investigation.
Pregnancy are ruled out. That's the major thing for me after that.
Investigation. Complete blood count, total and differential counts are normal. Hemoglobin 10.2 gram percentage. And routine REM, routine examination and microscopic examination were normal. Serum TSH was normal. Urea, creatinine, normal liver function test, normal. ECG, chest X-ray, but within normal limit. Then tumor markers. CO120.
Can I interrupt now? Before sending all these investigations, you want to confirm your diagnosis?
You routinely do chest X-ray, ECG for any gynae patient comes? LFT, X-ray, ECG? Now, this is all pre-op evaluation we are
you
doing.
want to confirm your diagnosis.
This is by ultrasonography and
so you want to do an ultrasound.
Yes. Ultrasound of lower abdomen.
Okay. You want to do abdominal, vaginal? I think always first abdominal, then
vaginal.
Vaginal ultrasound. Yes. So in the ultrasound, what all things you want to, how you want to start?
The ultrasound report of the report was both ovaries were bulky.
First, you will look in this for the cervix, like isn't it? There
Something is wrong.
Yes, madam.
I have internet. Okay.
Okay. So
Okay, now
cervix,
specific.
yeah, specific. Go on
Both of-
telling in ultrasound. You will see cervix first. Look for any
cervix,
Nebotian cyst or something.
Nebotian cyst
And
or any
then-
other cyst, and ovaries were bulky and complex cystated cysts were seen, and left ovarian cyst measuring 48 into 30 millimeter, and right ovarian cyst measuring 35 into 23 millimeter, and report says it was suggestive of endometriotic cyst.
So what are the ultrasound findings in the endometriotic cyst like? One important, how they appear?
Here the ultrasound report is incomplete. And if
Yes.
the oncologist has given this kind of a report, then you need to resend to him or her, or probably you didn't copy the entire report. You just restricted yourself to the ovaries and the cyst, etc., etc. But then, as Dr. Latha said, you must look at the cervix, you must look at the uterus, you
Yes,
must look at the contents of the uterus, the endometrial lining, and then you go to the adnexa, and then you decide all these things. I think this report is incomplete. So do not
Incomplete, sir.
report
Yes.
as a complete ultrasound report.
Yes, sir.
And which type of USG you will prefer in this case? You haven't mentioned that, like abdominal. Yes. So
okay.
Anyway, you also first thing is you want to rule out whether it's a benign or malignant, isn't it? So
Yes.
what are the features of benign ovarian mass like by ultrasound?
Benign masses are generally regular in size and contour, and size generally less than 10 centimeter. There was no septa and no papillary projection was seen generally, and there was no ascites or any or in Doppler study, no high blood flow is seen in benign ovarian masses.
Okay, so the wall will be regular,
Regular.
no solid components,
No solid component, papillary projections.
no papillary projection, or even if they are there, they are less than 4, isn't it? And length of the solid or projections will be less than 7 millimeter,
7
isn't
millimeter.
it? And they are usually unilateral, but
Unilateral.
and no ascites.
No ascites, no peripheral metastasis.
Can you, by ultrasound, can you characterize, like ultrasound, normally benign masses, can you name them by ultrasound, which all benign masses we can see, like endometrioma, isn't it? Or hemorrhagic cyst, or a dermoid, or a cystadenoma. Or
cystadenoma.
So can you characterize them like by ultrasound? Can you say like how does the endometrioma appear? Usually
In
they have
endometrioma,
ground
will
glass appearance.
ground glass appearance, homogeneous ground glass appearance.
And no color, isn't it? No,
No
color.
color.
And usually thick walled.
Thick walled cyst.
Yeah. Then hemorrhagic cyst, they have
Hemosiderin.
appearance, isn't it? And isn't it? They have a cobweb like mesh like appearance.
Like appearance.
Yes. What about dermoid?
Dermoid cyst, it shows multiple.
Yes.
There will be
What are the
multiple
features?
tooth-like
So it can cause shadowing, acoustic shadowing will be there.
You can say low level echoes with
acoustic shadowing, isn't it? And no color flow. It is very important because no patient once know that it's a benign, they will be very happy. And if you characterize in and come to an not as likely like HP histopathology, but at least some idea you should have before. Characterization of the cyst is very important by ultrasound, isn't it? All right.
I just want to know from Shulagna and Tamal.
Yes, sir.
Written that ultrasound, both ovaries are bulky, that's okay, complex septated cysts. Measuring the sizes you have mentioned, right ovarian cyst measuring so and so, and left is so and so. Suggestive of endometriotic cyst. What only size alone cannot suggest endometriotic cyst. So what is there inside the cyst, and what was the description of the cyst? That is important. When the sonologist gets an impression of endometriotic cyst, seeing what they have suggested this.
Homogeneous low level echo and ground glass appearance.
Oh, they had written that.
Yes, and most of this.
Okay.
POD is also obliterated if they are bilateral endometriosis. No, you cannot, both will be in the pouch of Douglas.
Pouch of
Usually
Douglas.
that is the common feature we see, isn't it? You must have seen a lot of endometriotic ultrasounds, isn't it? Those two will be in the, most of the
Pouch
time
of
it is
Douglas.
pouch of Douglas, both. Kissing ovaries we
Kissing
call
ovaries,
them. Yes, yes. That is again highly suggestive of endometriotic
Endometriotic
cyst.
cyst.
You think they are quite large, the size endometriotic cyst? Or what is your opinion on this?
It's a moderate size.
They're not
Moderate.
very big, isn't it?
Very moderate size.
Moderate size. So how do you?
Why did you proceed with tumor markers?
Yeah, hi.
What is it? Tumor markers? Which body fluid is this? Tumor marker, what is it? Urine, blood,
Serum.
ascitic fluid?
Yeah.
What is?
Serum.
Why did I ask? Can you do it in urine also? Yes or no?
It can be done or no? Urine.
Yes.
Can be done.
And
Which one?
Nowadays, new research has said which
beta,
one?
Which one?
beta ICG we can do it.
Beta ICG and other tumor markers. That's a new research thing, urine, because you're getting
And
plenty in
from urine.
amount.
Yes.
Why you have not completed tumor markers? Anything else you want?
Anything else other than this? CA, CA 19.
CA99.
Why?
Plan.
Nowadays, to what is Roma?
Roma, risk of ovarian malignancy assessment.
Yeah, to improve your specificity and sensitivity,
Yes,
along
yes.
with Roma CA125, now something new has come.
HE4 human epididymal.
Yeah, are you doing that? HE4, okay.
HE4.
You can add, yeah, LDH also you can add here.
Yes.
Why you want to do this alpha fetoprotein, beta SCG, LDH? What you have in your mind, like where they are all increased?
Germ cell tumor.
To rule out other germ cell tumor and sex-cord stromal tumors. To rule out.
Yes.
Sex-cord stromal tumor is by which tumor marker of these four?
Inhibin.
Which is
Germ cell tumor can be diagnosed by inhibin.
Sex-cord.
Granular cell tumor.
By the which tumor marker?
Which tumor marker?
Inhibin. Inhibin.
One more.
Other than inhibin.
Yes.
PLAP. Placental. Estrogen level.
Estradiol is all right, increased. Okay. Any other?
You finished with tumor markers? Okay, why did you do CT scan? What were you planning to do? Anyway, it's 3 centimeter, slightly of what are you thinking? Endometriosis. But why CT scan planned? Were you planning something? Management? Or we don't do routinely everyone CT scan, 32-year-old, she's clinically fine. Coming more of dysmenorrhea, I'm suspecting some ovarian mass or endometriosis. But why CT scan? Why were you planning?
Yeah, this question will arise because clinically we didn't find ascites in this case, and also no systemic disturbances like gross wasting of this thing or lack of appetite, loss of weight, etc., etc. So CT scan, it's a bit questionable. It's good that you have done, but you have to explain this. Why? Looking for what? Looking for what you have done CT scan?
Looking for any kind of
Big lymph node metastasis.
Why are you going so far? Lymph node metastasis?
We are more concerned about any deep endometriotic lesion or any addition.
Is CT scan good for that diagnosis?
No, MRI is good for that.
Ashish said, actually in government hospital, CT scan facility is easily available than MRI. So when there is confusion regarding diagnosis, usually we send the patient for CT scan. So
these are two very frequently misutilized investigation I found. One is color Doppler, and another is this CT scan or MRI. By the drop of a hat, everyone is sending patients for color Doppler and CT scan or MRI. So students at least should know
Yes.
the applicability or usefulness in diagnosis, if not individual sensitivity, specificity, negative predictive value, etc. They should know where one investigation is justifiable, where the other is not. Affordability comes later.
Tamal, you were talking about a deep infiltrating endometriosis. Something you said, DI.
Yes.
Yeah.
What does it? What do you mean by that? What do you understand by that?
When the endometriotic deposits in the peritoneum or any other structures go
What are
beyond
those structures? What are those structures? Like if they are involved, then we call it as a DI.
generally uterosacral ligament or any other
Bladder,
bladder, bowel,
ureter,
intestine.
bowel, isn't it? And more
Yes.
than 5 millimeter invasion. isn't it?
Invasion.
Yeah, but they cannot be diagnosed so easily by ultrasound. So sometimes you have to, yeah, it requires little learning curve. So you may have to take a help of MRI.
MRI.
And when you suspect it is when you have narrowed down to endometriosis, sometimes to confirm your diagnosis, MRI is better than the always CT. Is it?
CT scan.
Characterization. And when you suspect, so what are the symptoms of DIE like? They can have?
It causes dyspareunia, infertility. There may be history of infertility and
difficulty or painful defecation.
painful defecation.
Yeah,
Painful.
urinary increased
Urinary
urgency.
painful.
It's a bladder endometriosis. Okay, so there.
3D. You have to remember 3D for endometriosis.
In fact, one more D also. What are those 3Ds? Madam was asking you, what are those 3Ds? Yes.
Already.
Dyspareunia, dysphagia, dysuria.
Okay, and one more is depression. No? So
Depression.
much they will have pain and all these things. They'll
Yes.
go for a depression. Yes. Okay.
So we are going to close this session in 5 more minutes. Would like to have
I have last question.
Management.
Yeah,
Manage.
Before management, Tamal Sulagna, you did all the CT scan. Why do you want to have this grading classification? What is the idea?
Correct.
Do we have any gold standard for this? Is there a gold standard for classifying DIE? You were speaking of DIE, bilateral endometriomas. Why do you want to classify?
Yes.
Principles. She has come to you. You have done all CT scan, tumor markers, everything. Why are you doing?
Basically, we
First thing, yeah.
we want
Explain.
to know the invasion, how much the endometriotic lesion has invaded.
Severity, tell. You want to know the severity. Then, if not this patient, for other patients also, if she has nulli gravida, if she's coming to you,
Yes.
32-year-old nulli gravida, if she's coming to you,
if she has suffered from infertility, then infertility.
yeah,
index.
you want to know about the fertility scope later. So you
Yes.
want to know the severities of symptoms, explain to the patient in a simple terms. You want to know the fertility of the status because you have to proceed. That's why you want to know by doing all this investigation, you'll be grading it. Do you have a gold standard nowadays?
Can you name that?
Classify gold standard, because finally you are telling about more of bilateral endometriosis.
Great.
Is there or no?
X-ray and ASRM classification and
First
NGM
thing is
classification.
say no, we don't have gold
Yes,
standard.
no.
We are using a clinical consensus with many
Yes,
classifications.
size and
So
number.
we apply some and then we'll come. We'll do it. Because everyone will start fighting with their own classifications. So we don't.
Yes.
I mean. Okay, proceed then. You directly planned for
1 to 6
surgical.
patients.
Why did you go for
15.
surgical? Treatment, you have already surgical. Why did you directly go for surgical? You want to do surgical?
The size of the endometriosis is more than 3 centimeters.
Okay, this lady you planned surgical. Do you think?
What are
Okay,
the
fine. If she has
advantage
come
and
as nulli gravida to
disadvantage
you,
tell?
In this case,
what?
Yeah, we have
in
taken
nulliparous patient, we should prefer oral contraceptive pills.
No. Okay, you proceed with this lady. Okay, you planned for
Yeah.
surgical. What was the idea? Why did you think of surgical?
What were the advantage you thought you would give her by doing the surgical, and what are the disadvantages when you have taken this route?
Because you already first thing you have written surgical.
Yes.
First of all, we should remove the endometriotic implants and
Why do you want to remove? Leave it alone. Surgery is difficult. Endometriosis.
No, it will.
See, what will happen? She has a long time to attain menopause. What is that? What are you trying to prevent?
Preserve her fertility. Preserve her ovary mainly.
She already has 2 babies. You want to prevent the severe progression of the disease, right?
Yes,
At least to control, arrest the progression. That's why you're directly written surgical.
To minimize her pain
Okay,
and
because, she has a long way to
Symptomatic
attain menopause.
Menopause.
So minimize it. If at all she was nulli gravida, would you directly go for surgical?
no.
Why? What will you do before planning anything? 32 years, 5 years married
Nulli
life, nulli
parent,
gravida. If she's come to
nulli
you
gra-
with these symptoms, this is what we are praising. What is this month? What is this month with your case? What are we doing? Celebrating this month as 1st March. This is the month for endometriosis. 1st March is endometriosis awareness month. Your apt case is there for this month, right?
Yes, yes.
March month. So obviously, we get a lot of patients, where our infertility is there. Nulli gravida, 5 years married. She comes to me with this picture. Should I proceed with surgery? What should I do?
What surgery will cause more harm or benefit? What it can do to the ovarian reserve?
You give me an idea. What should I do if she comes to me at this?
At first, we do medicine. We prescribe some medicine, medical management.
I want to get pregnant. So I'll come to you, madam. I'm 5 years married life. I have these symptoms. It's more likely endometriotic cyst. I want to get pregnant. What do you do to me? What will you assess first thing?
If she came for infertility, then we have to remove the cyst by laparoscopic, mainly laparoscopic cystectomy.
Oh, all your fertility specialists won't agree with you.
Agree. Why they won't agree? Because it can reduce the ovarian reserve.
Ovarian reserve.
Ovarian reserve.
So check for my ovarian reserve. Depending on that, you proceed with the management. Okay. None of the nowadays the latest is the fertility specialists don't agree with going for cystectomy. Either you're using coagulation or you're using a suturing technique, but still they are worried it will reduce your
ovarian
reserve. And nowadays the new trend is most of the affordable people are going for freezing their eggs and then going for surgery. Even the common people are approaching with that.
Okay. So
because endometriosis spoils your reserve. It will destroy your ovarian reserve.
What are the other disadvantages of surgical? What you expect when there will be a lot of bowel adhesions, bladder adhesions, isn't it? So there is always
injury to bowel or bladder.
Yeah, risk of and also what is the procedure when you do the dissection of ureter? What is that called as? Ureterolysis, isn't it? All this and there will be more adhesions in the future, isn't it? And sometimes even surgery we will not be able to see the disease can be hidden inside, isn't it? So even after surgery, you may have to treat them also medically.
To prevent the recurrence.
Yeah, because all the disease cannot be seen by laparoscopy. There will be hidden disease also. No? Endometriosis is like that. Okay, and so risk of recurrence is also very high. Yeah, that you should explain to the patient party. Total medical. What are the drugs?
Medical options you have?
Yeah. Just name those drugs.
List the medical options. Anyway, she's not planning pregnancy.
Yes.
We can give her oral contraceptive pill, just hormonal pill.
Hormonal pill, GnRH, analog,
agonist,
and
antagonist.
No, new things have come out, no? New things.
GnRH antagonist new. Can you name that? Oral, it is available.
Oral.
Looks
quite good, like no, it has come in the market now. Oral antagonist, GnRH antagonist. Because what are the side effects of GnRH agonist? Why we worry so much?
GnRH.
We can't give long term, no? Yes. And hot flashes, osteoporosis. These are the two things, isn't it? So we have to give.
Other than your GnRH, OC pill, progesterone, anything else you know?
Anything else? New things? One more new molecule? We should know. Just
aromatase.
Yeah, aromatase inhibitors. What is SRPM?
SRPM, selective
Progesterone
Progesterone
receptor
receptor
modulator.
We can use all these things.
Yes.
Even dynogest
Long
also.
time, we need patience also.
Suppose she wants definitive surgery and she is now 45 and she wants definitive surgery.
At the age of 45,
We do total.
we'll do PHBS. So
Total abdomen. Hysterectomy.
That's an old term. Don't use. I tell my students, just because you have completed your life, do nothing. You can't discard your uterus and ovaries. Okay. Anyway, if patient wants it, you remove it.
Wants it, then you have to. That is a definitive, isn't it? So what is the risk of this bilateral? Anything in the future risk is there? They have cyst means any carcinoma or
Yes,
any
there is
risk of endometrioid
endometrioid cancer.
It is like a very devastating disease, endometriosis. You know, it causes a lot of morbidity. Slowly, it will kill the woman like that. You know, pain. So, can you tell because cystectomy? Can you tell what are how it is done? Cystectomy, any precautions? Laparoscopic hysterectomy.
When we do it laparoscopy, we have to cautious about the spillage and ovarian reserve.
Spillage still can happen.
Spillage happens.
Yes,
it
can happen.
We can use.
And we have to remove the cyst wall completely. Otherwise, it can recur.
Yeah.
Amal, can you stop sharing the screen? It will give better visibility to all the faculties and students. Please stop sharing the screen as it becomes good.
Almost done, Nafis. Almost done. They finished their treatment.
Okay,
Also,
please carry on. Just share the screens. Stop sharing the screen so that we can have better.
No, if they have something to show about the treatment, then they can.
Okay, you can proceed. Show it.
Yeah, they can proceed. Yeah, sir. That is better than others.
Yeah. So go back to the share screen option once again and just show us the treatment you were talking about, laparoscopic. That was your plan. Okay, that's okay. But anything else you wanted to show, or you just finished over here? This is your planning. Okay.
This was.
If you want to show, you can show. Yes, sir.
This was our case, and this is the laparoscopic removal of the cyst.
Excision of the cyst. Okay.
Excision of the cyst. This picture is, and then the specimen was sent for histopathology investigations, and reports suggest endometriotic cyst of both ovary, and cyst walls lined by hemosiderin containing histiocyte, and there is no evidence of malignancy.
Finally, your diagnosis endometriotic cyst.
Yes, ma'am.
Other than cyst, can you get any other findings so that you will tell that this is endometriosis when you put a laparoscope? What are the other findings you can have other than endometriotic cyst?
Other than endometriotic cyst, it may be Serra cyst.
No. How does the
laparoscopy findings?
Deposit of endometriotic deposits in ovaries and uterus actal ligaments.
Yeah,
that powder burn spots. They use the terms.
And there may be endometriotic deposits around it.
Yeah, jelly-like substances we can see sometimes.
Yes.
You know, peritoneal windows we can see. You know. Okay.
Yes.
Gunpowder.
So how do you follow up and advise?
Just 1 minute. There are few queries by the students. They are interested to know few things. I think we answered these also. They were saying that one should consider ectopic para-ovarian also as a differential diagnosis.
Yes, definitely.
Right.
Paratubal.
Yes. And the standard question is that where will dermoid cyst will be felt?
Most commonly in the anterior fornix because it's floating and usually commonly, it's not necessary always.
Yeah. So because of its content, the contents are heavy and they gravity by gravity. There is a physics now where the because of this heavy content, it is more likely to be the anterior fornix, and that is why more likely to be for getting torsion also. So these two are interlinked. Yeah. Then
someone has asked cutoff for HE4. Actually, HE4 alone we don't use. along with the Roma and CA125 because it is in
CA125.
the age group, because it increases the sensitivity and specificity.
And what is this
Cutoff even I
cutoff
don't
to
remember.
suspect
Cutoff even I
More
don't
than
remember.
5 in
Okay.
case of premenopausal
Yeah,
and
if you 50 less and 50 more we have to use.
yes.
Age
So what is the
lesser than 50 years.
what is the cutoff to suspect ovarian malignancy? 5, 7, or 10?
In premenopausal women, over one score should be less than 5, and postmenopausal women it would be less than 4.
Okay. No, this is for size of the ovary.
Mass cutoff for HE there.
Cutoff size of the ovary to suspect ovarian malignancy, or it is 5 centimeters, 7, or 10 for any mass. If you are
10,
feeling
10
in the
usually the larger the
10.
mass,
10.
less than 10 is the usually cutoff taken
Yes.
in the IOTA
10 centimeter.
guidelines.
IOTA guidelines.
Guidelines they have taken as 10.
okay. And what is new oral
But
GnRH
it changes
antagonist?
as per the
Elafolics.
Agabolics.
Agabolics.
Okay. Okay. So I think we have a very good understanding of
Elagolics.
this endometrioma and this benign ovarian mass. It can be anything. It can be dermoid, it can be serous adenoma, it can be endometrioma, or sometimes you are worried about or you are
Peritoneal
puzzled with
cyst.
peritoneal cyst, para-ovarian cyst, and you are sometimes puzzled with the functional cyst also. So there are a lot many
Yes,
things
sir.
which you have to understand. So thank you all. Thank you, Dr.
Thank you.
Ashish sir, and
Yes.
all my expert, Dr. Asha, Dr. Meena, Dr. Lata. Thank you very much.
Thank you.
And Dr. Hafiz, are you there or you are not there?
Yes, sir, I am there, sir.
He's there.
Yes.
Yeah, please, you can start, please. So,
No, just a minute.
Ashok sir,
Before Dr. Ashok goes into it, I'll just put 2 or 3 points
Yes,
here
sir.
and there and give it over to Dr. Ashok Kumar, who is going to present a very important session on how to do the obstetrical examination. So students don't go away anywhere. Now, my comments will be, number 1, the surgery or ovum pickup first in cases of subfertility, which have been discussed. It's a very tricky issue, and postgraduates should know that today the concept after the 2022 guidelines has come over, and it's quite tricky issue. And most of the fertility specialists will say that, well, I will take out the ovum, pick up the ovum first, go for FET, and then he will go for the cystectomy, while others will object to that and they will go for cystectomy first and then go for the ovum pickup. That's a very tricky issue, and you need to take a decision and take a call on each and every patient individually. It has to be individualized. There's a lot of noise in the background. I don't know why. The second point is the role of GnRH antagonist in this fertility and endometriosis has been still debated, but the new molecule that has come out, which is available orally, has made the job easier for us.
Easy.
It decreases the flare of the GnRH agonists, which have been so commonly used these days up till now. But yes, the trials are still going on. The final word hasn't been written yet. The third, a small correction, it is not SRPM, it is SPRM. That means progesterone receptor modulator. And that is actually, initially we had 5, but at present we have only 2. And what are those things that you should know? And their role in endometriosis and their role in fibroid uterus, you should know and study in detail. I have no time to explain them. And the fourth point is endometriosis, you need to have a balanced decision or judgment about which way to go. I mean, you should go for the ovulation induction and medical management first, or you should go for the surgery, or in new medicine that has, I think that Dr. Latha was asking was about the Dynogest, and they should know in detail. But remember that the fertility potential is a very important issue in patients who are seeking for fertility. Dynogest mainly relieves the pain, and therefore it is not very well recommended for the subfertile couple. So with those comments and a lot more to study in between lines for these Roma and HE4 and all those things, and risk of malignancy, everything you should study in detail for the examination purpose. For now, we have a very interesting session coming up by Dr. Ashok Kumar. We're going to take about how to do an obstetrical examination. Students, stay tuned, please. Over to you, Dr. Ashok Kumar.
Yeah, thank you, sir. very important and very means lot of marks are allotted to examination point, and one should be very careful. But it is a routine part. Now it should become as a routine. It should be without any fault. The examination should proceed, and it gives lot of information and it helps us in diagnosis also. So I am sharing my screen and just to see if it is visible. Yes, I can.
Yeah, make it full screen, please.
Yes. Yeah. So
Visible, sir.
when we start examination, we should not forget the general examination also. Although my topic today is obstetric examination, but a few important points in general examination which we should be careful about. General appearance, gait is very important. By how the patient has come to your in your OPD chamber or in the ward, how she is moving around, her height, weight, pallor, pedal edema, icterus, cyanosis, clubbing, lymphadenopathy, and don't forget examination of oral cavity. Ask her to open her mouth and just see how is the oral health. Then thyroid, breast examination, especially the nipple and areola, and then systemic examination, all system. Then we come to the our obstetric examination. There are few important things which you should be keeping in mind before you start obstetric examination. First of all, you explain about her what you are going to do. Ask her to lie down, but before that, ask her to void urine. Then you stand on the right side of the patient and always maintain privacy of the patient. Then only you will obtain or get the confidence from the patient also that you are very careful. And try to drape properly. I'm not saying that you drape with OT clothes and everything. You drape properly either with bed sheet or even the dupatta or sari of the patient can be used to cover her properly, exposing only the area which is required, right? And you expose the area from xiphisternum to the pubic hairline. You're not going there down at the moment. And never touch the patient to uncover the patient. Always ask the patient to uncover herself. These are very important points which I am highlighting here. Then patient should lie down in a dorsal position with thighs and knee partially flexed. Her head and shoulder should be slightly raised and supported by the pillow. And use your palm for palpation, not the fingers. You are not poking the patient. Use your palm or the palmar side of the fingers to palpate the patient. Now, first of all, you have to inspect the abdomen. So you have uncovered the patient is uncovered from xiphisternum to the pubic hairline, and you are seeing the abdomen of the patient with gravid uterus. So what you will see, what will you inspect? You will look for the distension is already there. Look for any asymmetry of the abdomen. And if it is an advanced pregnancy, you may observe fetal movement. It is not mandatory, but if you observe, please note it down. Then you have to observe the uterine contour. It is spherical, flattened anteriorly, cylindrical or pendulous. And always make a note of the suprapubic area. Is there any bulge in the suprapubic area or it is flat, as we have talked about in the morning also. Then size of the uterus may appear unduly enlarged or it may be smaller. It may be more pendulous, falling forward. Then presence of cutaneous signs. They are linea nigra, stria gravidarum or stria albicans. Then look for any surgical scars. Scar of previous cesarean, scar of laparoscopy, scar of any other operation in the abdomen. And you should try to correlate that scar with the historical event. Always mention that this scar corresponds to because of that surgery. Then umbilicus. Umbilicus may be flat, everted. So you have to comment on that. It may be because of intra-abdominal pressure which is increased. Now here, then the hernial sites. In hernial sites, sometimes the mistake is you include all hernial sites. But here we are looking at umbilical, inguinal, and any scar for any incisional hernia. We are not, see, femoral site is not visible in this field. So if you are mentioning femoral, then you be ready that how you have examined, how you have looked for the femoral hernia. So that, please be careful about that point. A cutaneous sign, linear nigra is a dark pigmented line stretching from GP sternum through umbilicus to suprapubic area. Striae gravidum are recent stria, are purplish. Striae albicans are old stria, they are silvery white, and they are evidence of previous parity. Then on palpation now. Now we are coming to the palpation. Usually we are able to feel the fetal parts after 20 weeks, and we are able to feel the fetal movements after 20 weeks by putting the hand over the uterus or the lower part of the abdomen. Another important sign is external blotment, which is usually elicited as early as 20 weeks when fetus is relatively smaller than the volume of amniotic fluid. But sometimes it is very difficult to elicit in obese patient, in oligohydramnions, and when advanced pregnancy is there at that time, but it is best elicited in breech presentation with head at the fundus of the uterus. So it is easy to ballot the head at the fundus. With breech at the fundus, it becomes difficult in advanced pregnancy. Now, how to do palpation? Now we start one by one. So fundal height is our obstetric examination. And in obstetric examination, the fundal height we have to measure in centimeter as well as in weeks also. So this diagram illustrates how will you put your hands. So gravid uterus may be displaced to the left or right side of the midline. So examine which side is the uterus. Mostly it is on the right side. So uterus should be centralized by putting your right hand. Here, it is very important to observe the position of the hands. We have observed in the exam the crisscrossing of the hands also. So try to be very systematically putting your movement of the hands and putting your hands in organized manner. So that is very important. So just see your right hand is in this position, like ulnar border is above. This is above. Sometimes you put in another way around also. So these things are not acceptable. And your left hand is at the fundus. So you start from the ZP sternum and slowly you come down till you feel the fundus. And here, just keep a note that you are not pressing on the abdomen. If you keep on pressing, you can come up to the umbilicus also. So these 2 or 3 points are important, that you are not placing firmly on your hand, because uterus is a soft organ. And you have to be careful that you start from the xiphi and then slowly you come down. And this you all know, I don't need to say anything on this, that if wherever you feel the fundal height, that will be the corresponding weeks. The below umbilicus you divide into 3 parts, then upper umbilicus also 3 parts, and then at from uterus comes down, and then it becomes below the costal margin, around at 36 or 34 or 32 weeks also sometime. So this all you know. But the important thing which you have to understand is this, that your hand is at the fundus and you slowly come down. Now, here you see that you are pressing very hard, right? So that thing you should observe, that you will not press it very hard. Slowly, if you keep it here, it will stay here only. But if you keep it pressed, you can come 2 weeks or 4 weeks further down. So that discrepancy then occurs in your examination findings. So be careful about this. I think it is stuck. I just wait and see if it goes down.
Is the slide stuck, Dr. Ashok Kumar?
Yes, yes.
Then in that case, you have to
After video, it happens sometime, na?
yeah.
I am stopped sharing at the moment. I will just go there and just see if it is moving. No, it is not moving.
So you share
Just
once again.
just wait. Just wait. I am closing this again and I will restart. Sometime it happens after the video PPT starts. Uh, yes, I am again.
Before you can start, can I just utilize this time and make one small
Yes.
comment? Yes.
Yes. Meanwhile, you can comment. Yes.
Yeah. The what I wanted to put in here is that while doing inspection, we have been traditionally teaching the students that inspection should always be done from the foot end of the patient. That way, you can see the bilateral, symmetry in the uterus while moving with respiration, etc., etc. So, whenever you listen to the question carefully, if the examiner asks to inspect also, I mean the local examination total, then you need to do the inspection first. Quickly go to the foot end of the patient, and then come back to the right side of the patient for palpation. There is one point. Second point is, Dr. Ashok Kumar, do you mind if I put a mark on the fundal height? Because you see, if you go on pressing, students have this tendency, as I said, that they will press very hard, and in the process, they will reach umbilicus very soon. So in that case, as a soft, gentle marking of the fundus, and then just putting a skin marking pencil, and just keep it there so that it is useful for the future references.
Yeah, it is useful. It is useful.
Yeah.
But obviously, before putting any mark, ask the patient.
Take a consent,
Because
consent,
yes, ask the patient, because some patient may not like that her abdomen is used as a drawing board. So one should be very careful about putting the mark on the abdomen.
Yeah.
Right, sir. So next, after finding this fundus, which fundal height, which is very important, and you correspond it to the corresponding period of gestation in weeks, then you have to, as soon as
this video is creating all problem, I think.
I think I will not use video. I will just, or I will move it in the, in this format only, probably. Yeah. So next point is you have to measure it in the fundal height in the centimeter. You have to measure in weeks, because that gives you again some accuracy about the period of gestation. So here, because we are measuring in period of in centimeter, but to avoid biasness, if you see this measuring tape, it is showing the examiner the inches. So you measure it in inches and reverse the measuring tape and try to see how much centimeter is there. So that way you avoid the biasness, because you know already the gestational age of the patient. So that way one should be very careful in avoiding the biasness. The important thing which you have to understand here is that you first have to, fundal height we have put the mark. Now, with your right hand, you try to feel the pubic symphysis. Try to go from the suprapubic area and try to feel the bony prominence. That is very important, because until unless you mark your two ends, you cannot measure the fundal height in centimeter. So it is important that you measure the pubic bone and fundus of the uterus, and then put your measuring tape as shown here in, and this inches is upward, and try to measure the height. So this way, now there's some measurements they have mentioned, is from 20 to 36 week gestation, the fundal height should be 2 centimeter either side of the gestational date. Suppose it is 32, then it may be 30 to 34 in centimeter. From 36 to 40 week gestation, this increased to 3 centimeter, and the fundal height should be 3 centimeter either side of the gestation. At 40 weeks, it is 4 centimeter, because it has descended down. The fundal height rises at the rate of about 1 centimeter per week between 18 to 30 weeks. After 30 weeks, this is not the case. And Between 20 and 30 weeks, infusofundal height of the uterus correlates closely with the POG in weeks. So this is very easy. Till 30, 32 weeks, it is easy to say whatever is the fundal height in centimeter. And important, one more thing which I want to highlight here is we never, when we measure the fundal height by our palpatory method, we never say a fixed value. We always say fundal height is suppose 32 to 34 weeks, or it is 30 to 32 weeks. We never say it is 30 weeks, 32, because there is some marginal error which may be there. So we always put a range when we describe the fundal height by palpatory method, but not with centimeter. Centimeter, it is accurate. So that is why it is very important that your fundal height by palpation, where you will put the mark, you should not put excessive force and should not come down forcefully. It should not be less. So that will give you a wrong fundal height. So after that, the next thing we do is the abdominal girth. It is in inches. We do it in inches at the level of umbilicus. And it provides information regarding the increase or decrease in uterine size in third trimester. And abdominal girth increases by almost 1 inch per week after 30 weeks of gestation. And then there are few more terms you should know. I will not go into the detail. Is the lie, it's longitudinal lie, oblique lie, transverse lie. You should know all these definitions, because these are the things which can be asked at the time of examination. And in the presentation, presentation refers to the pole of the fetus that present at the pelvic brim. Right. So it can be vertex, brow, face, or it can be breech, it can be shoulder. So they're different things. So because now we are going to palpate the abdomen or the uterus and try to feel for the fetus. And here we use obstetric grips, right? We can tell as a Leopold maneuver, we can use Pavlik grips also. These are the few terms which we will use now. So first grip is the fundal grip. And again, you are on the right side of the patient and try to see how you are putting your hands there. Your hand should be opened up like this and then over the fundus. You are not like this over the on the by side of the midline. You should be very careful that you are feeling the fundus here like this. And this is first Leopold grip. You are placing your hands on either side of the uterus and move them up to the fundus to identify fetal pole. So you may find breech or head with pulp of the fingers. Now, what will be the findings when it is a breech? Breech gives the finding of soft, non-palatable, irregular, large globular mass. So 4 adjectives you have to remember. Always 4 objectives when you're describing the fundal grip. For head, it feels hard, round, regular, and palatable. So 4 adjectives. If you are not saying 4 adjectives, I think examiner will not accept. Next is, if you see this again, fundal grip, hands, the position of the hand is important. And then comes the lateral grip. The flat palms are placed on either side of the maternal abdomen. You see like this. I think now I can go to the, I will not continue with the video. I think if it works. So see the side of the hand, how you put your hand on the side of the abdomen. And then stabilizing one hand, you try to feel other side and try to feel what is there. So a deep pressure is exerted using one hand to steady the uterus, this one, and other hand palpates the fetal part gently. Now, what will you feel here? You will feel either the fetal bag or you will feel the limbs. So fetal bag is felt as a continuous firm band of resistance, whereas fetal limbs feel like small irregular knobby parts on the side where the limbs are there. So these are important, and it is very important how will you describe your findings. See here, if you see your one hand is pressing steady, and other hand is moving above and downwards to examine and palpating what you are palpating beneath your hand. Try to find which part of the fetus is there, right? So you are locating or identifying the fetal bag in relation to the right and left side of the mother. The second thing you are doing on this grip is to determine the fetal position, the relationship of the presenting part to one of the quadrants of the mother pelvis. So these two information we are getting on this grip. Then you come down. Now here is the confusion. In some books, different ways are mentioned. So I will just highlight here the different things which you should understand, but try to follow whatever is there in your books, and you should be able to quote that I have read from this book, so it is written that way. So examiner will not question you if he has read some other book. So what I am going to say is now is the first pelvic grip. This is the first pelvic grip, and the other side, when you put the face down facing the feet of the patient, that becomes the second pelvic grip, and these are Pavlik grip. But if you go by the Leopold maneuver, this is the fourth Leopold, third is the last one. So there is a confusion here. Different books have given different. So we are doing first fundal grip, then side lateral grip, then this is the first pelvic grip or first Pavlik grip, right? But if you convert this into Leopold, this is fourth Leopold maneuver. So this first pelvic grip is you are using the thumb and the finger of the right hand, and lower portion of the maternal abdomen is grasped just above the symphysis pubis. You see the position. You start with your ulnar border. You put your ulnar border over the pubic symphysis. You have to first identify the pubic symphysis with your. You have to put feel that, and accordingly you put your hand ulnar border. The thumb, you see, where is the thumb? Thumb is on the right side and four fingers on the left side of the abdomen, and ulnar border of the palm at the upper border of the symphysis pubis to grasp the non-engaged presenting part. So you have to understand this. The purpose of this grip and position is very important. This is the commonest mistake in the examined by the student. Their position of the hand is not proper for this grip. They will put very above. If you see here, the thumb and the index finger or the other four fingers, they are very much in the lower part of the abdomen. Then only you will be able to feel the presenting part, that means head, non-engaged head. But what we have seen in the exam, you put your hand and then your thumb and fingers comes in the middle part of the abdomen. That immediately gives that impression that you don't know the method of examination. So what will be the finding? If presenting part is not engaged, you will find a hard palatable mass, which is head. Again, four adjectives you have to qualify. And if it is deeply engaged, then you will not be able to palpate the head, non-engaged head. So you have to be very careful. You are telling so many information by doing this grip. See the position of that. I am showing the different pictures to identify you. You should identify the position of the. It is in the lower part of the abdomen. It is just around the area of the pubic symphysis. It is not in the upper or the middle, midway between the umbilicus and the pubic symphysis. This you should be very careful. So determine if presenting part has entered the pelvis. That means you are finding the engagement and non-engagement. And to find the head at the pelvis and to determine the mobility of the presenting part. So then only you will be able to say whether it is non-engaged or engaged. If it is not mobile, probably it has gone inside. Then is the second grip. Second pelvic grip is the third Leopold maneuver. Because now you see the hands of the examiner, you have to face the patient feet. So you have to turn around and then try to see the feet of the patient, and then try to do this palpation. by both hands. So after facing the feet of the patient, the tips of 4 fingers of each hand are placed on either side of the midline above. And now just be careful about this point. Your hand should be on above and parallel to the inguinal ligaments. And then deep pressure is applied in the direction of the axis of the pelvic inlet. That means downward and backward over the pelvic brim to palpate the fetal pole. So what you are doing, your presenting part, the grip is useful even when the presenting part is low in the pelvis and you're trying to find out whether it is engaged or not. Right? And you know, when your hands are remain parallel, then it means head has gone down, it is engaged. The second, so you are getting what all information on this grip? You are getting the information of presenting part. You are trying to find out the engagement. And third is the attitude of the presenting part. Means your head is well flexed or not. A well flexed head in the left occipital anterior position, the fingers of the left hand can be dipped down towards the pelvic cavity before reaching the occiput, and those of the right hand as the sinciput at a higher level in deflex head. So you can find out the flexion or deflection or the attitude of the presenting part, head, for specifically for head. So that is also very important information you are getting on this grip. You see, your hands are parallel to the inguinal ligaments. This is very important to understand. Otherwise, you will not get the desired information. And this diagram you all should remember by heart because it will help you in correcting your findings if you are going wrong somewhere. If you see the topmost figure, here your hands, they are telling you the position of the head and it is telling you pelvic brim and ischial spine. Ischial spine is zero station and pelvic brim. And if it is your biparietal diameter is crossing the pelvic brim, then it becomes engaged. So all these things are shown here. So abdominal finding you are doing by fifth. This is not in early gestation, but patient who is near term. You have to mention all these things. In the fifth, you have to see how many fifth above the pubic symphysis the head is palpable. So, and then you are saying whether engagement has happened or not. And you are feeling whether you are palpating both the poles, one pole or the other poles. And in advance, in some patient, you have to do PV also until unless there is some contraindication. So you have to correlate with the station also. PV, you mentioned about the station also. So all these things should correlate when you are presenting your findings. If there is a mismatch, then we come to know that you are not aware of the proper labor or the proper obstetric examination. So that is why I have shown you this diagram that all levels should correspond to each other when you are presenting the case and presenting your findings. So after all these things, you are looking for the fetal weight assessment, which is done by placing one hand over each pole of the fetus and estimating the approximate weight, that is with experience. The fetus can be small, average, or big. So this by experience, it gives you a rough clinical birth weight, estimated birth weight. But now we have some formulas also and ultrasound also to give you the estimated fetal weight. The second part, which again you have to tell, is the volume assessment. It is the assessment of the amount of the lacquer volume and amniotic sac. So volume can be excessive, normal, or decreased, right? So if you, it depends on how easily you are able to feel the fetal parts, how easily you are able to palpate the fetal parts. That will give you with experience that whether the lacquer amount is adequate or not, or whether it is, if it is less, the fetal parts will be felt very easily. And then comes up polyhydramnios. If it is very much excessive, then it becomes polyhydramnios, and you have this fluid pill which you have to elicit. And you know that standard method of putting the eliciting the fluid pill, place the palm of your hand against the left side of the abdomen, flick a finger, but in between you put your other friend or the patient to put the hand in the midline, and then you try to flick with one finger one side of the abdomen and try to feel the ripple on the other side. So this way you elicit the fluid thrill also. Here you see the patient hand is there in between because no one is available around. So you can use the patient hand also, ask her to put the head in between. Then what you have to do? The abdomen, other than the growing uterus, should be examined routinely. So you have to look for other part of the abdomen also beside uterus. Usually we forget this. In early pregnancy, yes, it is very easy to palpate other part like liver, spleen, or sometimes we can find enlarged kidney also. But in advanced pregnancy, it becomes difficult, but you have to make an effort and you have to say, because in advanced pregnancy, like 34 weeks, 36 weeks, and if you're feeling, if you're examining a patient of heart disease or severe anemia, you have to tell us the finding of whether patient is in congestive cardiac failure or not. And then tender hepatosplenomegaly or tender hepatomegaly is an important finding which you have to tell us. So always palpate, try to palpate for liver and spleen after palpating your uterus. So these are important things which you should understand. And lastly, auscultation. You have to auscultate the fetal heart. We are doing with stethoscope, and we usually put in cephalic or vertex presentation. We are trying to find at the spino-umbilical line, umbilicus and the iliac, right anterior iliac supine, and then midway you will find the fetal heart, which is over the anterior shoulder of the baby, of the fetus. You try to see, right? And if it is a breech, it will move above the, because anterior shoulder will be above the umbilicus. So it will be on the above the umbilicus. So these are the different positions you should know in different, as we were talking in the morning about the occipital posterior, in different position where will be the best place to auscultate the fetal heart. So these all things are expected from you. Minute details are there. If you are not careful, if you are casual, that is reflected on your examination and it is being observed by the examiner and obviously by the patient also. So be careful about your examination finding. I think this ends my presentation. Dr. Ashish sir, and if anyone has comments or add on, rather to improve with this thing, it is most welcome.
Thank you very much, Dr. Ashok Kumar. That is extremely useful information for the students. I just wanted a little more clarification about the parvaginal digital examination, bimanual examination also. Because nowadays the parvaginal examination is not favored by many people. And particularly the examiners, old-time examiners, they always insist on the parvaginal examination and how far and how much they should do. That is one important issue. And adding to your presentation, sir, excellent presentation. I just wanted to make this thing. I already made my comments about the inspection. I think that has been noted. And then whenever the question of fundal height, the book teaching, standard book teaching is what you have shown. That is 20, 24, 28, 32, and then term size or 36 weeks or 36 weeks and term size. Whenever it exceeds that desired limit, I mean the specified limit of 32 weeks, I personally prefer not writing any range, like 32 weeks plus. That means it is on the upper side of the 32 weeks. Okay. So that is one suggestion that can be accepted. And another thing is that
may I interfere you here only? In the books and what most of the another observation. They're bulging. if flanks are full, if that observation is there in the inspection,
correct.
then one can differentiate whether this 34 weeks or 36 weeks is because of at a higher POG or it is at that POG. So that is another differentiated feature. So one observation which is very important at inspection.
Yeah, I believe that the postgraduates, after getting a rigorous training for 3 years, they are doing these things from undergraduate days. So after getting rigorous training for 3 years, they are authorized to make a comment on a term size uterus.
Yes.
That means what time the uterus becomes term size, it is their prerogative. Sometimes it so happens that, like you correctly mentioned, it may come down up to 32 weeks level, but it is term size uterus. So this discretion of describing a term size uterus goes to the postgraduates, and they hear the training and experience works. Our teaching actually works on that area only. The fourth point I would like to mention is there was a bit of confusion between Paulix and Paulix. I didn't understand that. I have to go through that again. I'll talk to you later about this. Vertex is not a presentation. It is a presenting part. It's by common colloquial language you have made vertex is a presentation. But actually it's a presenting part. The presentation is cephalic.
Cephalic, yes, sir. I have used the word interchangeably, but probably I think it is right. You have corrected it. Presentation is always cephalic.
Yes, yes. So some other day, sir, we will take up the provisional and examination because there are more amount of confusion about this.
No, PV is different. That is why I have not included here. I think it is only the obstetric examination. PV examination in labor or in pregnancy, how to do it, that is a separate thing.
PV examination in general, because now it has become very specific. So now, as the students, we must see that we are trying our best to include new things and the cases or places where you have confusions, and these confusions are particularly pronounced during examination. एक तो fear factor काम करता है, दूसरा external examiner factor है, तीसरा the burden of so much of knowledge, and you also think that what will be asked and what I can't answer, etc., etc. But our purpose, our idea is to make the students comfortable as far as practicable. We want to make them that you are very technically well equipped with the good techniques. Techniques are very important. Findings may different. Like in the case only, we saw that the students said that there was unilateral mass by clinical examination, but by investigation, it was found to be bilateral cyst. So that is possible. That is possible. And your clinical examination, you are substantiated with the investigation. That is okay. But your clinical examination technique must be normal. All right. So I would like to end today's session. Thank you very much, Dr. Ashok Kumar. That was extremely useful for the students, and I believe it has been observed by all the students all over the country. And in case some of you have missed it, please go to our website and you find that just yesterday I checked it, each and every lecture material is available. Each and every case presentation is available there. And I think make a good use of the ICOG website. Okay. So I think you will get everything. And thank you so much. Hafizur, a closing remark, and please close this.
Yes, sir. Thank you so much, sir. And we would like to have our sincere thanks to our FOGSI as well as ICOG chairperson, everyone, and to all the faculty, especially those has given their time, and as well as the students. And thank you, Ashok sir, as well as Ashish sir. Thank you so much. We would like to see on
any comments from the faculty. Any comments
yes,
from the faculty now?
Any comment? Yes.
Before we close, final comments.
Yes, sir.
Dr. Asha.
Yes, sir. It was actually thank you, sir, Dr. Ashok Kumar, Dr. Ashish, and Dr. Hafiz. It was a wonderful opportunity. I think we should take students from other states also. Quite useful, sir. That is, and this one was very good. Dr. Harish Doshi, what he demonstrated, occipito-posterior mechanism of labor. I think most of the students wants this. They want to observe these things, and as usual, Dr. Ashok, it was very good that you have demonstrated obstetric examination very nicely. And definitely, I think next part, like we can teach them about the PV examination in obstetric and also in gynecology. I think we should give them a standards, like then they will not make any mistakes in presentation.
Dr. Meena? Yeah. Please unmute.
Yes, sir. Thank you so much for giving me this opportunity. I really enjoyed, and this was the first, my experience that I was invited as a faculty for PG clinic. I would like to attend more, this kind of discussion, because recently I got two DNB students in my college, my department. And after, 15 years of my service, after struggling for long, I got two DNB students. So so I'm very happy to join this program, and I would like to attend. Dr. Hafizer, please invite me more in more classes.
Those two
And thank
DNPs
you.
have joined this session today.
Yes, sir. Yes, sir. Both are here.
Thank you. Dr. Lata? Please unmute.
Please unmute.
Unmute, Dr. Lata.
Dr. Lata, please unmute if you want to comment something.
Firstly, I want to thank Dr. Hafiz, Dr. Ashok, Dr. Shachi sir. And it's been honored to be here. And I would like to continue with this ICOG clinics if given again a chance. And my students are also there. I have 4 MD students per year. So there are a lot number of students. And it was really nice.
Thank you. Thank you, madam.
Dr. Chakravarti, madam.
Shivli, please unmute yourself.
Yes. Good afternoon, everybody.
Yes,
we
yes.
had two leading gynecologists, Dr. Sulabna and Dr. Tamal from CSS. He presented an interesting case presentation, and they have worked very meticulously for this presentation. After this brainstorming discussion and the thread-bearing analysis, I hope they have definitely learned a lot how to present and study a case, and it will be immensely beneficial for other examinees also. Thank you all.
I take this opportunity to congratulate Tamal and Sulogna. They did a wonderful job.
Yeah.
Yes.
So thank you all. On this Sunday morning, we close this. Thank you for being with us, and I hope we have done justice to provide you all the basic information from the clinical student point of view. Obviously, a lot of advancement and a lot of things are there. We have not gone into that depth, but yes, for the student, probably we have done justice, and I hope we are looking forward to your comments and feedbacks. Thank you very much.
Tamal and Sulagna, remember this is
Thank you, ma'am. Thank you.
Please
Tamal and
stop recording
Sulagna,
now.
remember this is endometriosis month for us.
Thank you, ma'am.
Thank you.
Yeah. Thank you. So everyone, I would like to see you on 14th April, that is next month, with a new program and the new topic as well as everything new. Thank you so much.
Thank you.
Thank you.
Please stop recording. Yeah.